Internal medicine is the biggest opportunity for points on the USMLE. It's over 50% of the exam and the secret to your dream residency match. While most students memorize isolated facts, high scores see pathophysiology patterns that connect symptoms, labs, and diagnoses into clear stories. When you master these connections, complex cases become obvious. In this private coaching call, I'm going to share the exact approach that transforms internal medicine from your biggest challenge into your competitive advantage. Last time we talked about making key concepts automatic. This is all in the service of, on your test, the more that you can automatically know what every sentence means, the better you will do. I can virtually guarantee that. You read a sentence and you just know what it means, your test is going to go much more smoothly. I don't think that's a controversial thing to say. The hard thing is to figure out, how do we do that? Last time we talked about making key concepts automatic. This idea that you want to be able to see someone that's hypotensive and tachycardic and immediately be thinking about the baroreceptor reflex. That's the first step. The second step, though, is to actually be able to put it together in an actual vignette and to drill these vignettes. What I've done here is I've created vignettes where we're going to A, drill those automatic key concepts. They just become something that you reflexively see when you're doing questions. But B, I'm going to give you cards and that you can then turn into vignettes that you can drill these concepts and continue to reinforce the connections. We're going to start with Hadra. The way that this is going to work, actually, all of you guys are going to read this vignette, and I'm going to call on Hadra because I want her to tell me what the pathophysiologic chronology is. But for all of these, I want you all to do it, and I will choose one of you to go over the pathophysiologic chronology. Everyone read this. You don't have to read it out loud, but I want you to tell me, what's the pathophysiologic chronology? Walk through the pathophysiologic chronology, and I want you to specifically tell me, what's the mechanism for developing type 2 diabetes? And why is he orthostatic?
The mechanism for type 2 diabetes is mellitus is that there is insulin resistance, and that insulin resistance results in increased insulin production and increased amylin production. And that amylin production, whenever there is increased production of proteins in our body, there is always going to be increased production of misfolded proteins in our body. And some of those misfolded proteins can be ubiquitinated, and others are not degraded by ubiquitination. And those proteins aggregate, and one of those proteins aggregating and through hydrophobic interactions is amyloid. When we have type 2 diabetes mellitus, we have a lot of insulin production because the cells are essentially resistant to proteins, and we have a lot of production of misfolded proteins, and we have a lot of production of amyloid, and that amyloid aggregates because of hydrophobic interaction into beta-pleated sheets, and then that actually deposits in the pancreas, and that results in dysfunction of the pancreas. Over time, the pancreatic beta cells become dysfunctional, and there is even more decreased production of insulin, which really results in a relative insulin deficiency.
That was really good. I am really impressed. I don't even think I need to teach that when I was planning on teaching. That was really good. Great. So why is he orthostatic? Walk me through the pathophysiologic chronology. How do you connect all this now?
It's this that obviously diabetes mellitus equals hyperglycemia. The blood has a lot of blood glucose inside it, and because of that blood glucose, there is non-enzymatic glycosylation of the arteries, and because of that, I think there is basically less blood flow. The normal response of when a person gets up is that initially when a person gets up, there is pooling of blood in their veins. And because of that, there is a decreased preload in the heart, because of which there is decreased stroke volume. When the stroke volume decreases, there is decreased cardiac output. And when the cardiac output decreases, there is decreased MAP. When the MAP decreases, there is a decreased stretch on the baroreceptor reflex. And there's a decreased stretch on the baroreceptor.
Okay, so that's good. You're walking through the normal healthy mechanism. What I'm asking is why
That's normal. But in diabetes mellitus, the nerves are basically weak because the blood can go to the nerves and it's not providing the nutrients. The nerves are not functioning at their best. When we get lightheadedness, and we have an alpha activation and we have vasoconstriction, that is basically being prevented, and the blood is not able to go to the person's brain, and that's why they're lightheaded.
Okay, how did that feel?
Yeah, that felt okay.
Yeah, that's not bad. It felt a little meandering at the end. In a test, it would be a little hard because I feel like the risk that you run with going into so much detail on the normal mechanism is that it's going to take too much time. Granted, this is a artificial scenario, but in an actual test, that would probably be a little, like going over the normal baroreceptor reflex is probably too much. But otherwise, that was actually quite good. What I'm going to show you is, this is the level at which, in an actual timed test, this is probably the level at which I would think about it. You don't have to go into details about how do you get diabetes. I asked you to go through the details of why you get diabetes. Someone was asking, what do you do in an actual test? What should you actually do in a test scenario? You can't go through, thinking about amylin. Every time diabetes, you can't be thinking of amylin production because of insulin resistance. That's just too much. You just say diabetes. In a test setting, this is about the level at which I would think about it. There's some sort of diabetic neuropathy of the autonomic nervous system. You get baroreceptor reflex dysfunction, and that's why you're getting hypotensive and orthostatic. That's it. However, when you're not doing this in a test, in a non-test scenario, I would want you to go through as much detail as possible. And the reason is because the more detail you can give, the more that this will become natural in your test, and the more that you'll be able to review it. Let's talk about some of this. This is the mechanism of type 2 diabetes, which Hadra just explained. There's insulin resistance that leads to overproduction of insulin. At insulin overproduction also, amylin is released along with insulin, which leads ultimately to amyloid production. The amyloid leads to beta islet cell dysfunction, and now you have a decrease in insulin supply to go along with increase in demand. And that is diabetes. Technically, it just means diabetes mellitus technically just means you have high blood sugar. This I took directly from the lecture Endocrinology, the diabetes mellitus and thyroid lecture. Briefly, to walk through the mechanism of getting amyloid, you have a protein. Some proteins, there's a non-degradable part. And if there's misfolding, you'll get ubiquitination of it. And if you're step one, they love ubiquitin, love the proteasome. It seems to always be the answer when that's one of the answer choices. You can degrade the degradable part, but the non-degradable part, the hydrophobic part, you can't degrade. When you're making more and more proteins, in the case of having insulin resistance and having increase in insulin, you will then accumulate these non-degradable parts. But the non-degradable parts will accumulate, and eventually what happens is that they polymerize. They now join together to form the superstructure of the beta-pleated sheet, which we call amyloid. Great. What's the significance of the fact that he had 20 years of diabetes and that is poorly controlled? Why did I say that in the vignette? And why do they say that in other vignettes? Virchow, what do you think?
You wanted to draw attention to the fact that poorly controlled diabetes can lead to the renal. Does the guy have renal failure? I forgot.
He had renal failure. Yeah, why did I say he had renal failure? Why was that important? Why would you have to include that? Or why would I include that in the vignette? Play directly into the orthostasis, right? It didn't necessarily play directly into the vignette, but it was still important. It's because the point is that a lot of these late manifestations happen similarly, concomititantly, right? Kidney disease oftentimes happens with like retinopathy, but if you're going to get peripheral neuropathy, it's also reasonable to think that you are at risk of having autonomic neuropathy. I was building towards this idea that he had autonomic neuropathy. Tingling in hands and feet may seem like a distractor, but really what it's telling you is just the overall state of his disease. If someone says, oh, this is someone who's got insulin-dependent diabetes, insulin-dependent type 2 diabetes, it just means it's really bad diabetes. Someone comes in with diabetes, they've got kidney failure, it just means that they have really bad diabetes and they are at risk of having these other complications. Great. We talked about this last time, but I don't want to spend too much time talking about this, but the normal baroreceptor reflex was what Hadra was going through. If I was going to make a tattoo, it would say MAP is cardiac output times TPR equals heart rate times stroke volume times CPR. And then preload, afterload, and contractility. Sometimes you can think about rhythm. And this is the mechanism. But hopefully you guys have, every single time that you've been standing up, you have been thinking about the baroreceptor reflex so that you can make this an automatic key concept. Because I guarantee if you're not drilling this into your head now, on the day of your test, it's not going to come to mind naturally. You're going to be time pressured. You're going to be stressed. This is the last thing you're going to be thinking of. The time to practice this is when you're not in a timed setting. When you're exercising, when you get up, when you stand up from a seated position, when you get up from bed, whatever it is. Right? But you want to learn how to make this automatic. Because the more that you can make knowing the right answer or knowing what every sentence means automatic on your test, the happier you will be with your score. I can guarantee that. We talked about heart rate last time. I don't want to spend too much time talking about this, but the reason that M1 causes an increase in heart rate is because of the phase 4 depolarization. Danielle, What's the equations for cerebral perfusion?
Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure.
Great. And how generally can you think about when I say perfusion pressure? What's a good way of thinking about that?
Resistance, is that what, like in the
Oh, no, like in general. If I think of blank perfusion pressure, what's the generic equation for perfusion pressure? That's a bad question. Basically, what's the pressure of the system that you're coming from? Right. In this case, it's the arterial system. Minus the pressure of the system you're going to, right? In this case, it's the brain inside. In general, because a lot of people would just memorize this. I'm saying you don't have to memorize this. You can actually make sense of it. The perfusion pressure on your brain is what's the pressure of the blood going to your brain minus the pressure inside your brain. Pretty much it. The other famous perfusion pressure equation, which we'll talk about eventually, is coronary perfusion pressure, which is usually written as aortic diastolic blood pressure minus left ventricular end diastolic pressure. Because your coronaries fill during diastole usually, at least the left-sided ones, and they're going to the heart, where ultimately, right, the blood is going to end up in the left ventricle. You're looking at the diastolic blood pressure, but it's coming from the aorta. It's ending up in the heart. The perfusion pressure is just pressure is coming from minus pressure is going to Hadra. Tell me, why is he lightheaded? Using the cerebral perfusion pressure equation, why does he get lightheaded when he stands up?
He gets headed because the MAP decreases and the intracranial pressure is high. Basically, the cerebral perfusion pressure decreases.
Yeah, I don't even know that I would say that ICP is high. The ICP is probably normal.
Okay.
But the point is that the ICP is unchanged. If this decreases relative to this, then yeah, your cerebral perfusion pressure is going to go down. Yeah. Cool? Yeah. Great. When someone presents with lightheadedness or syncope when they're standing, what's the general mechanism behind lightheadedness? And could this be a stroke? Pooja, can you tell us, what's the general mechanism behind lightheadedness and or syncope?
Oh boy.
Remember you were saying before, you were like, yeah, someone comes in unconscious. Yeah, I don't know what that means. What, you're supposed to know what that means? Yeah. Yeah, this is pretty much. Yeah, the general unconsciousness is a little different from syncope, which I'll explain. But yeah, it should be automatic. I've bolded all the questions that I want you guys to make into cards. We'll give you the cards.
The whole chronology.
Well, so yeah, there's gonna be two kinds of cards. There's gonna be the ones that I bolded. This is an automatic key concept. This is a concept that I want you to make automatic. When you see someone that's lightheaded, you want to think hypotension. In a very general sense, if someone's intermittently lightheaded or if they're syncopal, maybe not 100% of the time, but I'd say 90 to 95% of the time, particularly in questions, particularly for syncope, if it's truly pre-syncope or syncope, virtually 100% of the time it's going to be. I know there's going to be haters out there who are going to say, actually, technically, you can be syncopal from just, technically it's true. But that's really uncommon. That's hot air balloonists. Yeah, but in general, you should think hypotension when someone's lightheaded. I bolded this because I want you to make this an automatic key concept. In other words, I want you to be thinking about this when you see syncope. Oh, I know they're hypotensive. It should just come to your mind. That's what I want. Pooja, does that make sense?
Yes.
Perfect. I'm just spelling it out for you. This is what I wish that people told me. Pooja, can you tell me, could this be a stroke?
Could
if someone presents with lightheadedness, what's the likelihood that this is a stroke if they're lightheaded?
I think it could be.
No, almost never a stroke. That, I would argue, is probably a cognitive error. And I think if I had to reconstruct it, I think that the way that it happens is that people think of lightheadedness as a brain thing. Then your system one just goes, oh, headedness, brain pathology. Oh, what's a brain pathology? Oh, yeah, stroke. Strokes are brain pathology.
Here's a case where sometimes you do get a patient that comes in and says, the scenario will say, the patient comes in with the lightheadedness and the syncope, blah, blah. But then the vignette's talking about the symptoms of a stroke.
I've yet to see a vignette like that. Please bring that next time.
I'm not saying that I've seen it. What, again, I struggle with is when I see something like this and I associate it with the hypertension, am I going to lock myself in? That's what I kind of get scared of.
Oh, great. Yeah, exactly. This is why you have a system too, right? I'm not saying that if you say hypertension for syncope, you're going to be right 100% of the time. There's maybe a couple percent or 5% of the time where it's not going to be that. In other words, what was the trick of using your system two? What did we call that last time? Trust but verify. In other words, say, oh yeah, totally. I think that they are most likely hypertensive. But then verify. Do they have other symptoms of hypertension? When you look at the blood pressure, is it low? You still have to check it. I'm not saying that your test is just going to be like you're not thinking at all and everything is going to be automatic. No, absolutely not.
Okay, yeah. approaching questions with system 1 and I'm doubting my questions with system 1 as well. Like system 2 is like non-existent for me.
Exactly. What I'm trying to do with this is I want to strengthen your system 1. I want to strengthen your system 1 so your system 1 is giving you the right answer more frequently. However, we also need to strengthen your system 2 that it can take that answer and actually evaluate it and say, oh, does this make sense or not? But I think the problem is that a lot of you guys, your thinking is more to this. Oh, lightheaded. Oh, yeah, lightheaded. Oh, it's brain. Oh, brain problem. What's a brain problem? Oh, yeah, I think of stroke. No, that will lead you down the wrong path virtually 100% of the time. I've bolded this because I want to make this an automatic concept. When you see syncope or pre-syncope, you should be thinking hypertension, because in virtually 100% of, I'd say 95% of the time, just read fair, you should be thinking this will guide you in the right way. Maite said in her text to me, she said, I think it's good to think of stroke as focal neurological deficit, which is totally true. Trust but verify. What's the classic presentation of stroke? Well, the classic presentation of stroke is a focal, sudden neurologic deficit. You suddenly have trouble speaking, you can't move your leg or something like that. That's the classic presentation. Great. Next, Danielle, I want you to walk us through maybe just the overall big picture in terms of the pathophysiologic chronology.
Basically, this elderly man was born healthy, probably some poor life choices, a bit poor diet, maybe decreased exercise, led him to develop diabetes type 2. Well, led him to have insulin resistance, an increased insulin resistance, which caused an increased production of insulin to compensate for the resistance. And then this caused an increase in amylin. Do you want me to go through everything?
But I think that's big picture. That's actually, yeah, this is a delicate thing. I guess I would say when you're doing it on your own, I would want you to go through everything. For the interest of time, to make sure that we can cover enough vignettes, to reread it a little bit.
Since we already discussed the whole process of how type 2 diabetes occurs, I'll just go over that, skip that. Basically, his long-standing type 2 diabetes led him to have these kind of end-stage factors such as renal failure and the autonomic dysfunction. And the autonomic dysfunction caused him to have a baroreceptor reflex dysfunction, so he's not able to the job, like he stands up.
Keep cutting out. I think what you're saying is that he can't augment his cardiac output, which means his MAP doesn't increase. And because his MAP doesn't increase, his cerebral perfusion pressure falls. I think that's what you're getting at. What I've included here, the bolded questions, are the key concepts you want to make automatic. You see someone that's pre-syncopal, you should think hypertension. You should not think stroke. Pre-syncope or syncope, virtually, 100% of the cases, at least for vignettes, and even in the real world, is almost always because of hypertension. Vasovagal syncope, hypertension. Cardiac syncope, any of the causes, aortic stenosis, hypertension. Non-sustained VTAC, hypertension. All of them, they're all hypertension. In the test, this is about the level of detail. In a question, that would be one card, or the bolded things, we will include that. The other kinds of cards that I'm going to include is this one. The front of the card would be this vignette, and the back of the card would be this. And when you're reviewing it, should you do the summary or should you use the detailed one? Which do you think is better? Doralis, what do you think? If I'm reviewing this and I'm not in a time setting, which do you think I should go through?
Detailed.
Absolutely. Yeah. And a fair question is, Alec, isn't this just a god-awful waste of time? Why would I do that? Seriously.
Muscle memory for your brain.
Yeah, exactly. Because all of this stuff, I guarantee, certainly for step 1, but even for most of this for step 2, are things that are going to be on your test. Yeah, it's going to take you a little bit longer, for sure. But then you look at all the things that you're reviewing. It's crazy. There's all this stuff. And the other benefit is that, yeah, you're essentially creating muscle memory that the next time you see someone who has some form of autonomic dysfunction and they've got diabetes and kidney failure, and you're like, oh, I totally makes sense. Because maybe next time it's not going to be that they have, maybe it's not that they're going to have autonomic problems of their sympathetic system in terms of blood pressure, but maybe it's that they're going to have diarrhea. There's just no clear reason why. And you're like, oh, they've got tingling hands and feet and kidney failure. It stands to reason that they might have autonomic dysfunction as well. Maybe they've just got a problem with their sympathetic system into their GI tract. Their parasympathetic system's overactive and they're getting diarrhea because of that. You want to train yourself to be able to make these connections on the spot. And if you wait until your test, until you try to make them, you'll never make them. It's not going to happen. because it just becomes that much harder on the day of your test to do this in a timed setting when you're stressed. Just not going to happen. That was great. I'm going to ask all of you guys to read this quietly to yourself, and then I'm going to have Jarell walk us through what the pathophysiologic chronology of this one is. This one's pretty tough. Jarell.
Born healthy male. I guess he's probably had some unhealthy lifestyle changes or habits, that like with the smoking. And now at elderly age actually, I don't know where to go to here. I know what he
It's hard. This one's hard.
has, but I don't know how to get to from this.
Yeah, I know. Okay, does someone else want to give it a shot? This is one of the harder ones. But again, this is totally fair game for your test. Maite, you want to give it a shot?
A 57-year-old man used to be emergency department because working in neck pain, there can be a lot of things, but he had lightheadedness, 1 month history of upper mid-thoracic back pain. I think of something like the maybe aortic perissection.
Okay, so stop. But let me point something out to you guys. Your system 1 is unaware of time. Let me repeat this. In other words, your system 1 doesn't really know what happened first, what happened second, what happened third. It's just completely oblivious to time. You have to, if you're going to think about the actual chronology, you actually have to arrange the vignette in chronological order. I want you to actually arrange this in chronological order. What happened first and then what happened second, just in terms of the elements of the vignette. You don't have to tell me why it happened, but just which sense.
This was a healthy man, and then he started smoking, which is a risk factor to develop 20 years ago. That's a long time. And that includes your risk of a lot of things, but he has a CT that demonstrates that he has a mass on the pancreas. Maybe he starts smoking, this increases risk to develop pancreatic cancer, and pancreatic cancer develops his, how do I say this, hypercoagulability. Also, he kills smoke. It's a 67-year-old man who starts smoking, develops pancreatic cancer, made him to develop triangles. He has a DVT, and then he developed a PE, and the PE. Working in pain is because of the DVT, and then the DVT progressed to a PE, pulmonary embolism, that gave him the lightheadedness.
Perfect. That was fantastic. That was great. Do you see how different it is, though, for those of you that maybe weren't able to make all those connections? My guess is, as you were going, it was hard to tell because you were going down the wrong path. I don't think I was being very clear in what I wanted. But the key is that oftentimes what you'll see, this is exactly how they're going to give it to you in the vignette, because this is the chief complaint. He comes in, they might not even give it to you like this. They might even say a 67-year-old guy comes in with a 2-day history of lightheadedness, and that's it, because that's the chief complaint. And then they might tell you for a week he's had worsening left leg pain, and then they'll say he's had a month of worsening upper thoracic pain, because this is HPI business now. And then they're going to tell you about their smoking history, this 20-pack year history, way down at the bottom, because that's where the social history goes. What I see a lot of you guys do with your pathophysiologic chronologies is they're not actual chronologies. You're just going sentence by sentence, which is essentially what you were doing, I think. Right? That's not what I want.
I want to ask you a question while I practice, while I do my test.
When you do your test, do this. You should also arrange them chronologically in your mind, because it's hard. It's harder. Yeah. Because if you don't arrange it in your mind, your system 1's not going to do it, right? You're not naturally going to do this. No matter how many times you do questions, you're not naturally going to make those connections. I would argue that when I present it like this, I guess a lot of you guys were like, oh my God, I have zero idea what's going on. But if I were to present it like this in the actual chronology in which it happened, I didn't even tell you that he had pancreatic cancer. I didn't tell you any of the background of any of these things, right? I just now have just arranged them in order of the actual timing of them. It became much more clear what was going on when you arrange it in that order.
Yeah, I think as I finish, because when I read the vignette, I start taking space out and I finish before the dialogue, but I do it really quick. That's maybe why I think I might not do it, but yeah, because it's a second week, like I don't know how to explain it.
Pooja, what are your thoughts? If you saw it this way versus if you saw it this way, which is easier for you, Pooja? What do you think?
I think the bottom, it's a little bit more clear why one 20-pack year smoking history is the reason that he's got the pancreatic mass, is the reason he's got the weight loss, is the reason he's got the upper back pain. I would think that this would be the easier one.
Totally. Yeah. Are you naturally going to do this though?
I'm trying.
Yeah. I guess my point is that your system 1 will not do this.
Right.
Just reading a vignette, this will not become immediately obvious to you. Instead, when I read a vignette, whenever I see like days, weeks, I actually take an extra second and I actually think this happened first. I would read this and I would say, okay, so he's got leg pain and then lightheadedness. Oh, actually before that, he's got back pain, then leg pain, then lightheadedness. And they're like, oh, actually no, it's smoking, then smoking, back pain and mass, leg pain and lightheadedness. I actually think, and as I'm going, I'm trying to put those pieces together.
Well, if you think about that, then they should put the social history as the first thing in the vignette. So you
Well,
don't have
not necessarily, because the social history isn't always one of the key things. The reason why the reason why the H&P is laid out the way that it is because then you know what to expect, what to listen to in every step. You could argue maybe that you could put it in the HPI, but they will not always do that for you. They will not, both clinically and on your test. But I want you guys to see that it's much easier to see the connections if you actually arrange it in chronological order, which is why I keep telling you guys, you have to make actual chronologies. It's not sentence by sentence in terms of, that's not what a pathophysiology chronology is. You have to read it sentence by sentence. But what you're trying to build in your head is this happened first, this happened second, this happened third, this happened fourth. And I would argue that this is the exact same process that you should be doing clinically. Because if you just think about it in the order that the patient tells it to you, it is much, much harder for you to make sense of it than if you're saying, take me back from the beginning. When is the first time that you were well? Actually think, okay, try and make it in chronological order. So this would be the summary. As you're going through the test, this is about the detail that I would want you to go through it in a time setting. Smoking leads to cancer, pancreatic cancer, a lot of things. But in this case, it was the major risk factor for getting pancreatic cancer. And then smoking and pancreatic cancer are two, right? So what you guys didn't talk about was the fact that it's not just pancreatic cancer. He was smoking too. That's 2 out of 3 of Virchow's triad. That leads to DVT. Well, that leads to cerebral hyperperfusion. Of Virchow's triad, what are the 3 elements in Virchow's triad? Hypercoagulability, venous stasis, and endothelial damage. Danielle, what does Virchow's triad predispose you to, and how many are necessary in order to be predisposed?
Yeah, so it'll predispose you to getting embolisms and PEs and things that you need 2 of the factors.
Yeah, it's basically venous clots, CVT. Yeah, I typically need 2 out of the 3. Great. And Danielle, which elements of Virchow's triad does this patient have?
Yes, our patient has the pancreatic cancer causing the hypercoagulability, and then the long history of smoking, which is going to cause the endothelial damage.
Perfect. Smoking is endothelial damage. Pancreatic cancer is hypercoagulability. Great. Duralis, what does it mean when they say that there's a provoked or an unprovoked DVT? What does that refer to?
I'm not sure, but I'm assuming it has to do with if you're causing it due to something that you're doing, lifestyle changes, problems, or versus no.
Yeah, provoked basically means that there's a very clear precipitant, very obvious. Unprovoked is where it's not immediately clear what is causing it. And Hadra, which would be more concerning, the provoked or the unprovoked, and why?
I think the unprovoked is more concerning because in provoked you have a clear precipitant that you can take care of. For example, in our case, smoking, we could tell the patient to quit smoking. For unprovoked, I think we're more concerned as to now we have to dig in about the reason.
Yeah, what would you be concerned about?
Yeah.
Yeah, usually unprovoked are much more concerning. Oftentimes the thing that you worry about is genetics or some sort of undiscovered factor. For this guy, they didn't necessarily know that he had cancer. Presumably he didn't know he had cancer when he presented to the emergency department. It's a double whammy. It's, oh, by the way, you have DVT-PE. Oh, and by the way, you have pancreatic cancer. But the pancreatic cancer was that unclear precipitant. It was the one that you didn't know about. But that's what you really worry about. It actually happened to one of the professors at Stanford. He just developed a DVT. And it turns out, right, it was an unprovoked DVT. He was playing tennis. And it turns out that he has factor V Leiden. Wow. This stuff is real. That's crazy. But yeah, that was unprovoked. Great. Now I want to talk about resistors. Let's talk about resistors in series versus in parallel. So Luis, you can think about blood vessels, resistors in series or parallel. This is series. It's where one resistor is after the other, after another. I have no choice. I've got to go. If I want to go from this point to this point, I've got to go through all the resistors. If it's parallel, I've got a choice, basically. Technically, I'm not choosing, but there are multiple paths through the different resistors that I can take. These are resistors in parallel. Louise, can you tell us what's the total resistance equal to if there are resistors that are in series?
Would it be the sum of the 4 resistance?
Yeah, it is. Yeah. Total resistance is you just add them up. It's the easiest one. If I remove a resistor in series, what's the effect, Luis, on the total resistance? Going to increase it or decrease it?
It will decrease it.
Yeah, great. Right? Because it's just take this out, it's going to decrease it. Great. Pooja? For resistors in parallel, what's the total resistance?
1 over R1, 1 plus R2
Equals what?
equals, I don't know.
Does it equal the total resistance? Yeah. What does it equal to? Yeah, everyone remembers this side of the equation. No one remembers this side of the equation. It's actually 1 over R total. And I've made this mistake multiple times. I used to think that it was R total equals 1 over R1 equals, right? That's why I asked you, because I've definitely made that mistake before. But no, it's actually 1 over R total equals 1 over R1 plus 1 over R2 plus 1 over R3. Because that's important, because puja, what is the effect of removing a resistor in parallel? What effect, does it increase the total resistance or does it decrease the total resistance?
In parallel, I think it increases.
Yeah, it increases it. Great. Let's prove it. Let's prove it to ourselves. So let's just make the math easy. We've got 3 resistors. They all have the same resistance, and that resistance is 2. Not even using units, just to make it really easy. 1 over R total. This is for parallel. This is in parallel. It's going to be 1/2 plus 1/2, 1 plus 1/2. If we rearrange the terms, we'll find that R total, right, is 2/3. We agree? Now, let's say that we remove one of the resistors. Now, we've taken out R3, let's say. Now, it's just 2 resistors. 1 over R total equals 1/2 plus 1/2. But what do you know? The total resistance is now, it's one of those weird things, because I haven't really thought about reciprocals for a really long time. But do the math, prove to yourself that removing a resistor in parallel will increase the total resistance. Great. In other words, if I have a PE, what's it going to do to my pulmonary resistance? Danielle, would I consider my left and right pulmonary arteries to be resistors in series or in parallel?
Resistors in parallel.
Great. And if I had a pulmonary embolism to my right pulmonary artery, Danielle, what would be the effect on my total pulmonary arterial resistance if I were to think of them as resistors? This is a key concept. I've bolded it.
Yeah, if we're thinking about our pulmonary arteries in parallel, then if you were to remove or block our right pulmonary artery, then you'd be removing one of those resistors in parallel, then your total resistance would increase.
Perfect. Yeah, exactly. Excellent. Excellent. It's duralis. How could a PE lead to hypotension? That's a key concept.
Since the PE that it's in parallel and you're taking away one of the resistance on one side, it's causing an increase in total resistance though. Then that increase in total resistance is going to lead to a decrease in forward flow. That's going to cause you to have less blood pumping forward, including to your left side of your heart, meaning less stroke volume, less cardiac output.
Skipping a step, why is there less volume? Think of your tattoo. You're going to make a tattoo.
Okay. So anything that's in front, or I guess after the pulmonary embolism, is going to have a decrease in preload. If you have an increase in preload, it's going to cause an increase in volume to your left. Decrease in volume to your left atrium, which causes a decrease in volume to your left ventricle, and that's how you get the decrease in stroke volume.
Sorry, this might be a technicality, but really, I guess the way that I would think about it, and I think the way that they to test this would be, I would say there's a decrease in volume to the left atrium, decrease in volume to the left ventricle. That's great. I would say that means that there's a decrease in preload, because I think what you were saying, maybe I misunderstood, was that a decrease in preload leads to a decrease in volume. It's not usually how it's described physiologically. Usually, you think of it from the context of the left ventricle itself. There's a decrease in left ventricular volume, which means that there's a decrease.
Okay, that's true. Left ventricular and diastolic volume.
Correct. Yeah, exactly. Yeah, that's what you think of as preload. Not that preload leads to a decrease in your left ventricular inside. But yeah, decrease in stroke volume.
Decrease in stroke volume leads to a decrease in cardiac output, which leads to a decrease in your MAP.
Great.
Decrease in your mean arterial pressure means less blood in your arterial system, which means less blood to your brain.
Remember, the key is that you want to use these concepts that we just talked about. If you don't use them now, you're not going to use them on your test. It's not going to be automatic on your test.
I don't know what's the term for that. Maybe I wasn't here.
Perfusion pressure. Oh, you might not have been here. Yeah, cerebral perfusion pressure.
Oh, so is that the cerebral perfusion pressure equals
MAP minus ICP?
Because your MAP is decreased.
Yeah, your cerebral perfusion pressure is decreased. Yeah, exactly.
Okay.
In other words, larger PEs are more likely to give you hemodynamic effects to drop your MAP. And it's that decrease in MAP, which is ultimately decreasing your cerebral perfusion pressure. And that's where you're lightheaded. Great. Now, I want you to read this exact same vignette. Now that you've learned those key concepts, now that we've drilled those key concepts, right? Now I want you to read the vignette and I want you to tell me, because my hope is that now you're able to make the connections automatically much more. In order to further that, I want you to make this into a card and actually think, Why does he get a DVT? Why is he lightheaded? Why is he tachycardic? Hadra, can you tell us can you give us the high level? Don't go into really excruciating detail, but just the high level summary. And then we can save the excruciating detail for when you guys go over this on your own.
Yeah, the pathophysiology chronology will be such that this 67-year-old has been smoking for the last 20 years, and that's a risk factor for pancreatic cancer. And both of those are risk factors. They kind of make the Virchow's triad. There is endothelial damage and there is hypercoagulability, which results in DVT. And the DVT from there dislodges an embolus, which causes PE. And that PE actually increases resistance to blood flow. And there's decreased cardiac output, which decreases the MAP and which decreases the cerebral perfusion pressure. And when the cerebral perfusion pressure decreases, and the decrease in MAP also results in activation of the sympathetic outflow because of the baroreceptor reflex.
Perfect. Honestly, that's okay. Like that level of detail, because again, I want to train you in two ways. I want to show you when you're going through this in a timed setting, you have to know which details to cut and which to not, right? What are the big picture elements that you need to still have a complete story, a reasonably complete story, versus what are you going to do when it's on your own and you want to go over these details because these are details that could certainly be tested in other. In a test, this is it. I'd say smoking pancreatic cancer leads to DVT to PE, low MAP, perfusion, done. In a test, this is about as much detail as I would give. But outside of a test, this is the level of detail that I would try to do. I would even get down to the point of saying, yeah, you get a PE. The PE leads to you're removing a resistor in parallel, because that's a really important concept, thinking of resistors in parallel versus in series. And then, yeah, go through all of it. Cool? I think we might even have time for one more. Luis, I'm going to have all of you guys read this, but I'm going to have Luis go over the pathophysiological chronology. Luis, would you like to give us the pathophysiological chronology?
A 36-year-old woman who was born healthy. They don't specify for how long she has been smoking or using the oral contraceptives, but let's say that she was born healthy. When she gets to a reproductive age and starts having sexual activity, she starts taking the oral contraceptives, and she probably starts smoking as well. She probably develops a DVT, or
she smokes some CPs. Then she takes a flight.
That sentence in the chronologic sequence. She was a 36-year-old woman. She was born healthy. She smokes, uses OCP, and then she takes a long flight from South Korea to LA. From sitting down for quite a long time, she develops DVTs. During the flight, she gets to LA, and all of a sudden she starts complaining. She probably develops DVTs, and then those clots.
I want to stop you there. That was not bad. What I want to point out is that this is probably how a lot of vignettes feel to a lot of you guys. You're reading it, and honestly, you probably don't even give it as much effort as Luis just gave. You probably just I don't know, took your venous extension. That was clear. And you just you choose an answer. That's usually about the level that I think most people understand most vignettes. And there are two choices that you have when you see a vignette like this. The first is to just say, look at the answer, read the educational objective, and say, oh yeah, I get it. Oh yeah, whatever. I'll get it next time. The second thing, which is what I want you guys to do, is to actually go through and make sense of the pathophysiological chronology. I actually walk you through step by step when you have the answer in front of you. Because what you'll find, and the reason why I'm showing you, I'm very intentionally showing you the vignette at the beginning and at the end of each of these, is because I want to show you in the beginning, you're often not sure what's going on. But then afterwards, you're like, how could someone not see this? And Luis, this is what I want to prove to you. I want to prove to you that you're gonna be like, I totally got this. This makes total sense. And if you make a card on this, and if you repeat this card using detailed pathophysiological chronology every single time, when you see a question like this, and I guarantee you're going to see a question like this in your test, it may not be this exact same scenario, but it'll be very similar. You'll know it. You'll know it, because our goal is to make sure that you know automatically what every sentence is trying to tell you automatically in your test. This is the summary. Basically, she's, our previous guy, smoking and pancreatic cancer, was 2 out of 3 Virchow Triad. This lady's got 3 out of 3, smoking, endothelial damage, and she's got hypercoagulability, and because of the OCPs, and she's got venous stasis. She's got a whomping DVT, which becomes a large PE, that leads to right-sided heart failure. And the fact that it's right-sided heart failure is critical, because that's why she doesn't have crackles in her lungs, and that's leading to hypertension and ultimately, again, cerebral hyperperfusion. Cool. Let's talk about heart failure. Pooja, what does heart failure mean? It's kind of this vague term.
Well, the heart's not able to pump blood adequately or
Adequately for what? Adequate for what?
for the body's needs.
I know. It's the one time that the medical student answer is correct. Something really vague, but yeah, it's true. So basically, it's if you can't meet the body's blood demand, right? Or, right, you need excessive volume or pressure to do it adequately. The classic heart failure patient is they've got JVD up to their earlobe and they've got inspiratory crackles and all this stuff. That they have adequate flow to they may have adequate flow to their body, but they need so much volume to do it adequately. That's still considered heart failure. Let's talk about, Pooja, you had a question?
Yes, I did. About the previous vignette, when we were talking about the Virchow's Triad, when we're doing this on our own, should I think about what specifically in the blood is causing the hypercoagulability and it's allowing? I don't know.
If it was
I'm sorry?
If it was a time setting, what do you think?
Oh, no.
No, I probably wouldn't do it. Yeah. But if it was not outside of a test, maybe not every time, but I would say, yeah, you should think about what exactly is the mechanism which OCPs cause hypercoagulability. Sometimes I don't know. I don't really understand why cancer, I guess they say that there's mucin or something and it causes a tissue factor, I don't know, substitute or blah, blah, blah. But yeah. Yeah. But in theory, yeah, you should try to walk through exactly what, at least once. Yeah. Because the more that you walk through it, the more automatic you're going to make it on your test. That's the goal. As long as you remember that, I think it will make it a lot easier for you to think, oh, should I do this or not? Luis, do you have a question?
Yes, I was going to ask something related to the clinical vignette that I was reading. Usually the DVTs will be the cause for pulmonary. The DVTs, they will go into the pulmonary artery causing a PE. But then I got a little confused because when I saw the distension of the jugular veins, I didn't think of...
Let's talk about this. Let me ask you the question. So what are the signs of right heart failure? It's like I planted you there to ask that question. What are the signs of right heart failure?
Increased, jugular distension because of the overload in the superior vena cava, and from there up, basically a jugular vein distension. What else?
This is good. I'm glad that, basically almost everything that you think of as signs of heart failure are basically signs of right heart failure. Ascites, hepatomegaly, splenomegaly, venous distension, lower extremity edema. All of those things are essentially right heart failures. We should make that into, that should be something that you should know. You should absolutely know. That is a key concept that I want you to make automatic. Pooja, or I think we already did Pooja, Doralis, what's the mechanism of getting lower extremity edema in right heart failure?
Because for whatever reason, your heart is not able to either push that fluid forward, it's causing a backflow of the fluid. There's that increase in pressure due to the backflow.
Yeah, it depends on the cause. In this case, there's an increase in afterload for the right heart, but that's not always going to be true.
But you can, when you say increase in afterload, it could be calling it the right heart, and you would just have to say it as opposed to just...
Yes, exactly. You have to specify afterload for the right heart.
Anyways, there's an accumulation of fluid that is causing your heart to fail in the sense of not letting it push forward. That's going to cause that to move from the ventricle, all that fluid from the ventricle up to the atrium, and then go into your venous system. That tends to cause the JVD, the jugular venous distension.
Lower extremity edema. We're focusing on one symptom or one sign.
In the end of the day, all that backflow is just going to cause an increase in your venous system to the point that your capillaries have a high hydrostatic pressure and cause that filtration.
Yeah, exactly. Yeah. You get venous congestion, particularly in the dependent areas. Yeah, you have capillary. It's in the capillaries, not really the venous system. Your capillaries are the thinnest part. So that's where if there's going to be fluid leak, it's going to be across the capillaries. There's more fluid leakage in the interstitium. That's what gives you pitting edema. Great. Hadra, on a test, or just in general, how do you differentiate between left and right heart failure? Because they always say, the most common cause of right heart failure is left heart failure. How do you differentiate between that for combined left and right heart failure versus just having isolated right heart failure?
In isolated right-hand heart failure, patient will present with edema, hepatomegaly, ascites, JVP raised, but clear lungs. The lungs will be atmospheric clear. But in left heart failure, because of the backup of blood, the lungs will not be, and yes, we'll have pulmonary edema and pulmonary capillary wedge pressure will be raised.
Yeah, exactly. Usually what they'll say is they'll have inspiratory crackles. If they have a pulmonary artery cancer, which is pretty rare, but if they did, right? But both actual and real life, very few people get pulmonary artery catheters, but also in vignettes, they don't really have wedge pressure or pulmonary artery catheters that often. Almost always it's going to be the lung. I can't tell you how many times I'll see a question, it's about heart failure, and you'll say, oh yeah, you'll see pitting edema or something. And they have no idea why they're like, oh, clear lungs. Oh, it's because there's no pneumonia, or something that's completely unrelated. Oh, no. Anytime that they give you signs of heart failure, you want to listen to the lungs, both in real life and in your vignette, especially in the vignettes, because they're not going to come out and just tell you, oh, it's just right heart failure. They have to give you a sign that it's just right heart failure, to give you a sign. And really, they're really restricted in the signs they can give you, because almost every sign of heart failure is really right-sided heart failure. If there's signs of right-sided heart failure without pulmonary edema, you should think isolated heart failure. Sometimes, literally, that is the only clue that they're going to give you, and that's how you're supposed to answer the question. Now, I want to go back to Luis. Luis, it's always hard to be put on the spot. It's always hard to do these questions. But I want you to tell me, now that we've reviewed these key concepts, right? Now I want you to tell me, what's the pathophysiologic chronology here?
36-year-old woman is born healthy. She starts smoking and using oral contraceptives. She takes a very long flight from South Korea to LA, where she develops DVTs in her lower extremities. Those DVTs will go to the pulmonary artery as a pulmonary embolism that will decrease the preload. That will decrease the preload, causing a decrease in the stroke volume, causing a decrease in the cardiac output, causing a decrease in MAP, and causing decreased cerebral hypoperfusion.
That's awesome. It's really interesting. I heard you say you're PE causing, there's a lot of hesitation, decrease in preload. But then, did you guys hear? It was like decrease in stroke volume, decrease in cardiac output, decrease in MAP, cerebral hyperfusion. It was just like, that part was automatic. Did you feel that, Luis?
Yeah, basically what I was practicing from the sessions from Tuesday about just making sense of something and then just try it to be automatic. Once you get to the point where you understand the clinical vignette, and then just from there on, just try to connect what variable affects the other variables that's why just like you said, I hesitated a little bit, but from that PE for all the way to the decrease in the preload, the rest was basically automatic. A decrease in the stroke volume, decrease in the cardiac output, and then decrease in MAP, and then decrease cerebral brain.
But I think one of the things that you said that struck me was you said you've been drilling it since Tuesday, and now it's just become automatic. My thought when I hear that is that the same thing is going to be true for this vignette. Yeah, the first time that you saw this, it was pretty slow. The second time you saw this, part of it was slow, but other parts of it were faster. I guarantee that if you were to continue to just repeat this vignette, right, in your cards, and just the repetition, the practice, and make the connections every single time, that the next time you see this or a similar vignette, because there'll be similar vignettes, it will just be much faster, just the end of this vignette was. What are your thoughts, please?
Yes, I couldn't agree more. I think that if you just the rest of the Yankee cards, if you see the same card over and over, it doesn't matter if you don't study the card for a month or a month and a half. Whenever the card appears, then the basic or the idea of the card just comes up automatically, because you've been seeing it for quite a few months now. It doesn't matter if you go a couple of weeks without seeing that same concept. Once one of the either the back or the front part of the card, you automatically can recall the clinical vignette related to the card you were seeing. Yeah, I think that repetition is the most effective way of just remembering stuff. Because if you read it one time, if they change the clinical vignette and if you haven't practiced the key concepts of that card over and over, you might hesitate a little bit. I just did. I knew that it had to do something with the DVTs and the PE, but then I hesitated which was the parameter that was affected, in this case the preload. But I hesitated because I wasn't sure at the beginning, but then the rest of it just came out automatically. And I think it's thanks to the session we had 3 days ago.
Yeah, but it's because the other thing is, yeah, like you can see as you're doing the pathophysiological chronology of the question, you can see where the rough spots are. It's just telling you, yeah, maybe that's the area that we want to focus on. That's the area, because you guys were asking, what are you supposed to focus on? Focus on the parts that are slowest. I know it's more pleasurable to do the ones that are faster, but I think Pooja was mentioning before, it's really pleasurable. It's hard, but you get this sense of satisfaction when you can see a vignette and you know exactly what every single sentence means. It just feels good. It just feels awesome. And I can tell you, it feels doubly awesome when that question is on your test, your actual exam. You're like, oh yeah, I know what every single sentence means. I know why they're trying to tell it, why they're including it, why there's a print negative. You just get it. You feel like such a boss. Yeah. But it comes from, you want to continue to make these automatic.
I have a question. She had a PE, and because of that, it's causing the lightheadedness. But I'm assuming, I guess PEs can have different severities, because I guess this wasn't that severe. She's having no hyperventilation or like.
Oh, just because they don't say something doesn't mean it's not there.
But is that something like it might not have
hyperventilate? Oh yeah, if they told you her respiratory rate, it would be high.
Okay, so it's like a for sure thing. Like she actually is having trouble breathing and all that. It's just not like, oh, I feel kind of lightheaded, I might have a DVT. It's not anything like that.
In other words, the lack of a symptom doesn't necessarily mean that it's not there. This is one of my pet peeves about rule in and rule out, is that oftentimes you guys will say, oh, this is ruled out because if it was this, then I would expect all of these symptoms. That's not necessarily true. First of all, clinically, that's not necessarily true. The diseases don't present in the classic way every time. There is such a thing as sensitivity and specificity of clinical signs and symptoms. And that doesn't even work in real life, but it certainly doesn't work in tests either. In this case, the fact that she's not hyperventilating means that it can't be a large PE. They didn't tell you that her respiratory was normal. You don't have a pertinent negative. Does that make sense?
Yeah, that makes complete sense. Yeah, that's good to know that it can't just rule it out because it's not there. But I guess for future knowledge, PEs generally, like, it's not because like, oh, she had small.
Large PEs are the ones that are hemodynamically significant.
Okay, little ones probably wouldn't even cause lightheadedness.
Small PEs would not cause lightheadedness unless you were very fragile.
Like where you had some prior lung disease or something?
Yeah, if you had right heart problems to begin with, yeah, a small PE might be the one. But yeah, just think about it. A small PE is likely only to remove a very small resistor in your pulmonary arterial system. Removing a small resistor is not going to change your pulmonary resistance that much. A large PE is going to remove a large resistor from your pulmonary circulation. If you knocked out the right pulmonary artery, that's a huge resistor. That's going to cause a dramatic change in your pulmonary arterial resistance. That would be enough of a drop in preload to cause hypertension. But notice, I have made that concept automatic. This is a meta view, but you see how quickly that came to mind? It's because every single time I see these changes, either of increase in resistors or decrease in resistors, right? I see a patent ductus arteriosus, or I see an AV fistula or something like that, I'm thinking about it in terms of resistors in parallel series, so I can see it as a side note. But yes, to your point, large PEs are the ones that will cause hemodynamic changes. If you're serious about maximizing your scores, join our 14-day mini course now. We'll send you 14 high-yield videos that break down the exact concepts and test strategies our students use for 260 plus scores. Click the link in the description below now to get instant access. Today, we are going to transition to talking about GI stuff. And so I'm going to read this vignette slowly, as I would in the real world, and because again, slow is fast. And then we'll have you do the pathophysiological chronology. So, a 15-year-old boy comes to his physician for nausea and vomiting for the past 2 days after a school potluck. Several of his classmates and teachers reported similar symptoms. Temperature is 37. Blood pressure is 120/80, and pulse is 72. On exam, there is mild scleral icterus. Abdomen is soft, non-tender, and mildly distended. Labs are significant for T-bili 3.5, direct bili 0.3, alkaline phosphatase 40, AST 20, ALT 21. What is the pathophysiological chronology? What is the significance of the total versus the direct bilirubin? Is the alkaline phosphatase normal? And why would that make sense? And what color would his urine be? So I'm going to put this in the Google Doc, and then I will have you guys do that. Physiological chronology. So this is Gilbert. So in other words, if you said he was born healthy, that's not technically true. So he was born with the UDP glucuronoltransferase activity down for whatever reason. And so he was asymptomatic until he had a GI illness. When that happened, he had a decrease in the conjugation of his bilirubin, which led to an isolated increase in his unconjugated bilirubin. bilirubin. So that was why his total bilirubin was high, but his direct, in other words, his conjugated, was low. So if the idea of conjugated versus unconjugated or direct and indirect and all this stuff confuses you, this is the lesson for you. Also, if you're confused about AST and ALT and all that stuff, this is it. Whereas what we're going to talk about. So summary of key concepts. So as a reminder, bilirubin, right, is a breakdown product of heme, which is a porphyrin ring. Porphyrin rings are nonpolar. So again, I'll repeat all this stuff later, but this is just the overview. So when you break down heme, you get bilirubin, which is also nonpolar. It makes sense. Heme is nonpolar. When you break it down into bilirubin, bilirubin is also going to be nonpolar. Because it's nonpolar, if you want it to stay dissolved, or if you want it to not cross over and be absorbed by your GI tract, then you have to conjugate it. It happens to be conjugated with glucuronic acid by UDP glucurontransferase, and that's what's deficient in GFR. Porphyrin rings, interestingly enough, so they are nonpolar, and they're nonpolar because they have a lot of conjugated double bonds. And so they absorb visible light, which means they are, for our purposes, they have color. So heme is red because it's a porphyrin ring, because it absorbs visible light because of all the conjugated double bonds. Or bilirubin is yellow because, again, it's also very nonpolar, has an alternating structure of double bonds with single bonds. Myeloperoxidase, so why pus is green, is because, again, neutrophils have myeloperoxidase, also based off of a porphyrin ring. Chlorophyll also is a porphyrin ring. That is why it's green, right? All of these things that have color in our world, many of these natural things are based on porphyrin rings. And because they have this conjugated double bond structure, right? Where you have double bond, single bond, double bond, single bond, double bond, single bond, double bond, single bond. That is why they have that. That is why. It's cool. As we talked about, it's where you have decrease in UDP glucurontransferase activity. It leads to an isolated, unconjugated, right? In other words, an indirect hyperbilirubinemia when you have periods of stress like this guy had. And then as a final reminder, we're going to talk about LFTs, but as a reminder that it's basically a misnomer. They are not actual tests of liver function, and we'll talk about why. All right, so we've got a lot of stuff. So let's start with Leah. So Leah, what is bilirubin? You just have to remember, you have to unmute yourself. There we go.
So bilirubin is a breakdown product of hemoglobin.
Actually, specifically, so what's the difference
Heme.
of heme? Yeah, what's the difference between heme and hemoglobin?
Heme, there are 4 heme molecules in a hemoglobin.
Good, yeah, exactly. Hemoglobin is the protein, right, that contains the heme. Heme is the smaller molecule that actually binds to the oxygen. So Fong, what organ does most of the bilirubin in your blood come from? And why would that make sense?
You mean liver?
Actually not. No. The bilirubin goes to your liver, but what makes the bilirubin, so to speak?
So the spleen?
Yeah, very good. So why would that make sense?
Breakdown.
Yeah.
Mhm.
Yeah, because that's where your blood cells are broken down. Great. So bilirubin is a breakdown product of heme, right? So the spleen is where you're breaking down all that heme. So it makes sense. And so Satya, is heme water soluble or not water soluble, and why?
Heme has protoporphyrin and iron. I would think it's water soluble.
Let's look at the structure. So I included it here. So is this very polar or nonpolar?
It looks non-polar.
Very nonpolar, extremely nonpolar. You are correct. Yeah. So if it's nonpolar, is
So-
it going to be water soluble or not? Probably.
So it's not.
Yeah. It's very nonpolar, right? So you can just see, right? It's like, yeah, this is definitely not polar, right? So in general, right? So they say likes dissolves likes. It's an easy way to remember it. So water is polar. Things that are not polar do not dissolve well in water. So porphyrin rings absorb visible light. Io, what color is heme when it's bound to oxygen, and why? It's just red. This is why your blood is red. Right?
Oh, gotcha.
It's hard to be put on the spot. This is good. It's good practice because oftentimes the questions are easier than you think. So yeah, so porphyrin rings absorb visible light. And so as do basically many things with conjugated double bonds. Fun fact, again, chlorophyll, which gives plants their green color, also is a porphyrin ring, which makes sense because porphyrin rings have a lot of conjugated double bonds. The conjugated double bond structure basically allows it to absorb light in the visible spectrum, oftentimes. So most things like dyes have a lot of conjugated double bonds, just in general, if you're interested. So Matan, what color is bilirubin and why?
Yellow color.
Yeah, it's like yellow. Yeah. Why is it colored and why is it not without color?
Well, it doesn't have oxygen bound to it, so that removes the darker reddish brown. I'm not sure exactly why it's yellow though.
Again, same thing. Sorry, I think I should rephrase these questions. Really, it's not why does it why is it red or why is it yellow? It's why does it have color in the first place? It has color in the first place because again, bilirubin is the breakdown product of heme, right? Heme is colored, so it would make sense that if you break it down a little bit, that it would also still have color in it, right? Because again, both have many conjugated double bonds, and so they absorb light in the visible spectrum. You can see it. You can just see it here. You don't have to be a chemistry guru to see like double bond, single bond, double bond, single bond, double bond, single bond, double bond, right? Single bond, double bond. That is what a conjugated double bond is, right? Where you have that alternating structure of double bond, single bond, double bond, single bond. So when you see that, you should think both A, nonpolar, and B, that it is going to absorb visible. Again, I'm trying to make this is like chemistry for MDs, right? This is very simple. So what color is poop, Moise? And why does it have color?
It's yellow or dark brown.
Yellow, brown. Yeah, brown. Yeah. Why does it have color?
I'm not sure.
Because again, so it's because it all comes from heme, right? So ultimately, it's all coming from heme. So because you have bilirubin that's broken down into urobilinogen. The urobilinogen is broken down by so bacteria break bilirubin to urobilinogen, and from urobilinogen to stercobilin. So stercobilin is the brown thing. You can see it's very similar to bilirubin. It's extremely similar. And also it has a lot of the conjugated double bonds, right? Double bond, single bond, double bond, single bond, double bond, single bond, double bond, right? Cool? Nita. So what color is P and why?
It's yellow because it's a breakdown product of bilirubin or heme.
Yeah, exactly. And so it has a lot of what?
Broken up heme.
Well, it's a lot of conjugated double bonds, right? So the urobilinogen, right? Just like for poop, just like making stercobilin. But instead of, so some of the urobilinogen is reabsorbed into the bloodstream. Some of that's filtered. And then in air, I think with oxygen, it oxidizes. Presumably either from just the oxygen that's in the urine or in your blood. And so that becomes urobilin, and that is yellow. But again, you can see it's just the same thing. Like they all look very similar. So it would make sense that all of these things come from the same thing, right? Heme, and that they would be colored. Cool. What important immune system enzyme uses a porphyrin ring, and what color is it? Myeloperoxidase. So in the respiratory burst, right, this contains it actually contains heme, which is interesting, right? So it also contains a porphyrin ring. But pneumonia. What question can you ask to help you differentiate between bacterial and viral pneumonia, and why?
Maybe you could ask them the color of their sputum.
Yeah, you can. And that is actually what people do, what you're supposed to do. You say, do you cough? Is it productive? And then you ask, what color is it? So what color would make you concerned for bacterial pneumonia?
Green?
Yeah, green or yellow. What color would make you less concerned for bacterial pneumonia and think more viral pneumonia?
Maybe like clear, like normal color.
Clear. Yeah, exactly. Perfect. So you say, if there is sputum, what color is it? If it's green or yellow, that would indicate neutrophil presence. Since when the neutrophils break down, they're going to release their myeloperoxidase, which again contains heme. The heme, again, is a porphyrin ring, right? Blah, blah, blah. So it absorbs visible light, right? So if the heme breaks down a little bit, then you can actually basically get bilirubin. I'm pretty sure that's where the yellow comes from if you've got like yellow sputum. Cool? Yeah, all these things. Who knew? So Deb, so abuse, right? This is something that you guys should all, right, that are going to go into patient-facing specialties should be aware of. So if you suspect physical abuse, very few abusees will say, oh yeah, like I'm being abused. Oftentimes the way that medical providers will hear it is, oh yeah, I'm accident prone, or I fell down the stairs or whatever. What physical evidence can you look for that will help you confirm that it wasn't just they fell down the stairs one time, that it's actually like multiple episodes of abuse?
The location?
Yes, location is definitely one of them. So what about, this is not what I was looking for, but you're right. That is one thing. And that's something that shows up sometimes.
I'm sorry, what's your question?
So location is one of them, right? So you can get defensive injuries, right? So like usually it's their forearm. But what about the bruises themselves? How are they going to look?
Could it be because like frequent bruising and frequent?
Not just frequent bruising, but the age of the bruises. So remember, if a bruise is just bleeding into your skin. So when you bleed into your skin, the breakdown of that blood is going to follow a very stereotyped process, right? Meaning if I have 5 bruises all at the same time, they should all look the same as they progress. So if you just fell down the stairs one time and got a bunch of bruises, then all of your bruises would be the same color. They'd all be red. However, the thing that you should look for in physical abuse is look at the age of all the bruises. In other words, older bruises are going to have more bilirubin in them because the heme has had more time to break down into bilirubin, right? Like, sad that we have to think about this, but there is a scientific basis. Cool?
Very cool.
Yeah. So if the age of the bruises don't match, they couldn't have occurred during the same incident. So if some of them are red and some of them are reddish yellow, because the heme is broken down into bilirubin, they couldn't have all happened at the same time. I remember once my grandmother-in-law, my wife's grandmother, there was a problem in the hospital and she fell. And so you can do this also in radiology. So you can look at the age of, because you can see, because fresh bleeding is going to be more dense on a CT. So it'll look more dense. You can actually look at the age of, you can estimate the age of different lesions. Like if someone fell down once, so she fell, they were moving her and she fell from a very high height because she was getting a scan or something. And so we were looking at the CT scan and you could tell that there had been probably multiple falls because you could see that some of the bleeding was more dense, some of the areas of blood were more dense than others.
Alec, I have a question.
Yeah.
On one of the, I'm doing Kaplan now. One of the questions was basically comparing an epidural hematoma and I think it was either subarachnoid or subdural. But the pictures in the description, one of them was a really bright white, which was the epidural hematoma, and the other one was a darker color. Does it make a difference where the
That's actually exactly what I was just talking about. Yeah. So an epidural hematoma is going to present more quickly because it's an arterial bleed. So the blood is going to be more dense because it's going to be fresh blood. There'll be more iron there. So remember, if you remember from the cardio lecture.
The other one would be venous blood.
Yeah, whereas a subdural hematoma is typically subacute, and so there is much more time for that blood to the heme to break down and the iron to be resorbed, and so it will not look as dense.
I got you.
Cool. Yeah, same idea.
I totally messed up.
That was a great question.
I wanted to know, it wouldn't matter the size of the bruise in terms of the color. If someone hurts themselves in different areas.
Yeah, if I had a gigantic bruise, the color should be the same. It's the age that will tell what the color should be.
Okay.
So we are on, I think, Sujith. So Sujith, is unconjugated bilirubin water soluble or not, and why?
It is not because it's nonpolar.
Yeah, it's super nonpolar, right? Yeah. So again, it makes sense. Heme is nonpolar, bilirubin's nonpolar, so it makes sense that they would both be poorly water soluble. And so Feluke, so unconjugated bilirubin, will this be absorbed by the GI tract? Why or why not? You can, yeah, because again, it's nonpolar. So generally, nonpolar things cross pretty well. This is why urobilinogen, which again is a breakdown product of bilirubin, can be absorbed by the GI tract, and why it can end up in your bloodstream and ultimately your urine.
Thank you. I didn't know.
Yeah. So Feluke, what does conjugation of bilirubin do? Why would we do that? Why would we want to conjugate it?
It's to excrete it.
Yeah. So why? What about conjugation allows you to excrete it? You're right. Absolutely. But why?
Because we want to get rid of it.
Well, true. That's the teleologic thing. But physically, what do you conjugate onto it? Ty, what do you think? Why does the conjugation of bilirubin allow you to excrete it?
Because it's water soluble, it's able to be filtered out by the nephron.
True, but unrelated. You are correct. But we do not conjugate it so that we can pee it out. We conjugate it so that we can poop it out.
Should I give it a try?
Please.
So if unconjugated bilirubin is absorbed easily, then is conjugated bilirubin not absorbed easily, and that's why it could be excreted easily?
Boom. Yeah, because you conjugate it with something that's polar, right? That's it. So glucuronic acid, right? The acid itself probably gives part of it away, so it's pretty polar. So you conjugate it with something that's polar, so that way it doesn't get absorbed by your GI tract, and therefore can stay in your GI tract and you can poop it out. Good. All right, so let's talk about some of these labs. Let's try and dig into this. So Claudia, so what does it mean? What does direct bilirubin actually refer to? So we've got total bilirubin and direct bilirubin. So what does it mean to say direct bilirubin?
Is that conjugated bilirubin?
That is conjugated. It refers to the conjugated bilirubin. So technically, if you're curious, just if you're curious. So the way that they measure it is they add what's called a diazo reagent, which basically goes, so if you have bilirubin, there's going to be the water soluble kind and the not water soluble. So it's going to split like oil and water. So the diazo reagent is going to go, it happens to be more hydrophilic. So it's going to go to the hydrophilic part, which is the direct bilirubin, right? Because the whole point of conjugating it is to make it water soluble. So it goes to the water portion of it. And so that's why, and it reacts with it and makes it colored. And so that's basically, the reaction is what you're measuring. So it's called direct bilirubin because that's what you're actually measuring. That's the thing that you're actually measuring. They call it indirect bilirubin because it's the thing that you're only indirectly measuring. Kind of cool, yeah. So Saba, what does total bilirubin refer to?
Total bilirubin is both conjugated and unconjugated, so direct and indirect together.
Perfect. I meant to say Saba though, but that is correct. Oh. So Saba, what do you think? Indirect bilirubin. Use what it is to explain how you would calculate it.
I think you would do the total bilirubin minus the direct bilirubin to calculate the indirect one.
Perfect. Yeah, that's exactly right. So the indirect is the unconjugated, right? So it isn't directly measured, right? Hence the name indirect. So you can calculate it basically by saying it's the total minus the direct. That's it. So Saba, what would be what is elevated? Is it the direct bilirubin or the indirect bilirubin that's more elevated here?
I think it's the indirect.
Yeah, definitely. Because 3.5 minus 0.3 means that your indirect, right, your unconjugated bilirubin would be 3.2. So almost all of this is indirect. All right. So Miriam, where does conjugation happen? In what organ?
In the liver.
Boom. And so the biliary system is split into two parts, the intrahepatic and the extrahepatic. So Miriam D, what would be considered part of the intrahepatic biliary system?
I know there's like the main vein and then there's like all these cells right beside
It's okay.
it.
I didn't know this. I had to look it up. It's the right and left hepatic ducts. So Rosa, where's the extrahepatic biliary system?
It would be whatever is outside the liver.
Yeah, basically, everything that's not the right duct, so the common bile duct. Great. So this is just something that's interesting, but do you happen to know, Shama, do you know what's the difference between PBC, primary biliary cholangitis, which used to be called primary biliary cirrhosis, but they changed it. So PBC, primary biliary cholangitis, versus primary sclerosing cholangitis. Do you happen to know what the difference?
I believe so. Primary biliary cholangitis is what used to be called like primary biliary cirrhosis, and it's autoimmune in middle-aged women, and it's intrahepatic like fibrosis, like duct fibrosis, compared to like primary sclerosing cholangitis would be extrahepatic like fibrosis.
Almost, very close. That was exactly right, except that PSC is actually both extra and intrahepatic. Cool. So PBC is intrahepatic only, and then PSC is basically both. But yeah, that was good. All right, Leah. So unconjugated bilirubin. So use whether it is water soluble or not to explain whether an unconjugated hyperbilirubinemia would lead to dark urine. So if you have unconjugated bilirubin in your blood.
Yes, it is, because the unconjugated version is not water soluble, is what we talked about.
True, but why would it end up in your urine then? Because isn't your urine water?
So why would it go to your urine?
It doesn't actually. That's the punchline.
Okay.
So it doesn't lead to dark urine. I love the thought process, but yeah. So it's poorly water soluble, and because of it, so I want you to tell me why it would not lead to dark urine, because your reasoning was correct. It was just the final step.
So we said it's not water soluble, so then it is not going to be excreted in the urine, so it's going to stay in the blood.
Perfect. Yeah, because it stays bound to albumin. Most nonpolar things in your blood are bound to albumin, like just in general. Yeah, bilirubin being one of them. Or if you remember, like from biochemistry, right? Like free fatty acids basically bind to bilirubin. That's how they're transported in your blood. But yeah, so it doesn't, in other words, it doesn't end up in your urine. It stays bound to albumin. So how about Fong? So Fong, would a conjugated hyperbilirubinemia lead to dark urine or not? Why?
Yes.
It would. Good. Why?
Because it's water soluble and it secretes from the liver cell and to the blood and get to the urine.
Yeah, exactly. So another way that you can differentiate between a direct and indirect hyperbilirubinemia on questions and in life is look at the color of the urine. Right? Tea-colored urine or dark urine, it tells you that there's conjugated bilirubin, usually. Satya, so if you had a complete blockage of the common bile duct, what color would the stool be and why?
The stool would be pale because there's no bile coming in. And
yeah, exactly. Specifically, there'd be no, bilirubin coming in. So if there's no bilirubin, there's no urobilinogen. There's no urobilinogen, there's no stercobilin. And so there's nothing that's going to give the stool the brown color. So classically, they say like clay-colored.
Yes.
Yeah. Boom. Isn't that cool? I know what some of you guys were thinking at the beginning of this. You guys were like, oh my God, are we really going to be talking about porphyrin rings? Really? And he said that this was going to be step 2 related. So just by understanding that one principle, you can explain so much. The color of bruises, like how cholestatic, like how cholestasis is going to present, the color, like why you ask the color of sputum, why pus is green and yellow, right? All that stuff. So Io, if you had a complete blockage of the CBD, the common bile duct, what color would your urine be and why?
It would still be dark red in color, so it may still, well, it's blocked. Is there a way it could find its way into the serum
It
and
does. It does. Yes, it does. Yep.
and the filter through the kidney? It would be dark red.
Dark. Not necessarily red. Remember, because it's bilirubin, not heme.
Dark yellow?
Yeah, just like dark yellow. Yeah, just like normal color, just really dark.
Remember.
Exactly. Because again, it's because think, and it's because you have conjugated bilirubin there. It's not the heme. So hemolysis can give you like red blood or red. Myoglobinuria can give you red urine because the heme is still red. So the heme will make your urine turn red. And by the point that it's gotten to the common bile duct, you've got unconjugated bilirubin goes to your liver, gets conjugated, then goes into your common bile duct. So if this is blocked, then all that conjugated bilirubin is going to back up into your liver and then enter your bloodstream. And so it's the bilirubin that's getting into your blood. And so that, because it's conjugated, as you pointed out, stays soluble in the serum. So that will be able to be filtered through the kidneys because it's not bound to albumin. And so that will enter your urine and it will just make the urine dark yellow. Cool?
Yes.
Yeah. Matan. So what enzyme performs conjugation of bilirubin?
It's that one with the long name. UG. There's two of them. Oh, there it is. UDP on the right there.
Yeah. So it's UDP glucuronal transferase, right? So let's just break that down. So it uses UDP, right? So UDP is basically just the carrier molecule. So that's not really the important part for MD purposes. This is not the important part. The important part is the glucuronal part. So transferase just means it's transferring it. Glucuronal is the important part. So it's glucuronic acid. So I was just curious, so I looked up the structure. But yeah, so this is the glucuronic acid, this right here. And so what ends up happening is the bilirubin will bind to this right here, to this carbon right here. So again, all you need to know with this is that this is pretty polar, right? This is a carboxylic acid. There's a bunch of hydroxyl groups here, but yeah, this is pretty polar, right? This looks pretty similar to a sugar, basically. This is a pretty similar structure to a sugar, right? So pretty polar. So this is the same thing, right? Just written differently. And so this is bilirubin, right? So bilirubin, which is very nonpolar, now has bound to this polar thing. And by binding to this polar thing, it is going to make it polar. All right. So great. So Gilbert, what effect does stress have on UDP glucuronal transferase activity? So Nita, what do you think?
I'm not sure. I guess it would decrease the activity of the enzyme.
Yeah,
Sure.
good. That would make total sense, right? Why would it make, yeah. So I spent a long time looking. I was trying to find some really great principle that was like, oh, fasting or stress like always decreases liver enzyme activity, but it's not like that. It really is quite complicated. Yeah, this is just one of those facts you have to either accept or memorize. But yeah, so but again, remember, Gilbert always happens, like the classic one is like some poor medical student that's stressed and doesn't eat because they're cramming for a test or something, and then their eyes turn yellow because they've got an unconjugated hyperbilirubinemia because their UDP glucuronal transferase activity goes down. So, but yeah. So Gianna, so now use the genetic basis of Gilbert syndrome to explain what you would see on the liver function tests. What abnormalities would you see?
So I think as we discussed, the genetic basis was that it decreases the ability for bilirubin to become conjugated. So based on that, and we said that the liver is the organ that does the conjugation, right? Maybe you would have decreased liver function, but
Okay,
I feel
so sorry.
like
So we're going to talk about liver function tests next, but what if I should ask, what effects does this have on bilirubin? Total bilirubin, your direct and your indirect B.
so your direct would be lower because you can't conjugate it. Your indirect would probably be higher because it accumulates because it can't become direct. And then your total, would it be the same?
Usually higher, but I guess in theory, maybe it could be, yeah, depending on when you catch it. But if they're presenting, presumably it's higher. So in order to see jaundice, I think you have to have a bilirubin of at least 2.5. Yeah, it is. If they're coming in, it's because they're symptomatic. So yeah, it would be high.
Right.
Yeah, so good. So UDP glucuronal transferase activity is low. When they're stressed, it gets even lower. And so they can't conjugate bilirubin well. And so they get an isolated unconjugated hyperbilirubinemia. Great. So let's go through some labs. So Deb, so in our Gilbert patient, can you explain the bilirubin labs? So again, T-bili was 3.5, D-bili, direct bili was 0.3.
So the lab finding is indirect hyperbilirubinemia. This is compatible with isolated unconjugated hyperbilirubinemia in
Perfect. Yeah, so problem with bilirubin conjugation, more unconjugated, so your T-bili is up. However, because of the poor conjugation, your direct bili is not elevated, as Gianna pointed out. So good. And as you also pointed out, it's an unconjugated hyperbilirubinemia. Great. So the last part of this discussion is going to be about liver enzymes, and I wanted to talk about this in our first lecture because it's in all of GI is talking about the liver enzymes. So we're just going to go through this and we're going to make sense of it. So Sujith, what does LFT stand for?
Liver function test.
Great. And I put this in quotes, right? Because do you happen to know, Faluke, what's included in the LFTs? The standard LFTs? Like the normal, there's 4 things, basically.
Alkaline phosphatase, SGPT.
So bilirubin's one. So T-bili in direct. So usually it's total and direct. Sometimes they'll give you indirect, but usually they'll just give you total and direct. AST, which stands for aspartate aminotransferase. ALT, which is alanine aminotransferase. And as you pointed out, alkaline phosphatase, ALP, or sometimes you'll see AP, which are my initials. So I can always remember that one.
I have a question. What about GGTP?
Those are not part of the standard LFT panel, but you are correct. GGTP, gamma glutamyl transferase, is sometimes, right? But that's not part of the standard panel, usually. It's usually just these 4.
Thank you.
So TI, so AST, right? Aspartate aminotransferase and alanine aminotransferase. Are these normally found inside of cells or outside of cells? Like, in other words, are you normally found in your serum or are they normally found inside of some cells?
I think they're typically confined to the liver.
Yeah, they're a little bit more broad than that. I think he's like in muscle cells in general, and ALT is found in some other things. But generally they are only inside of cells. They should only be inside of cells. So in other words, AST, ALT, these are supposed to be liver cells, right? So they are normally found only inside of cells, not in the bloodstream. They would only be found in the bloodstream in very small amounts. So so when we measure these LFTs, what are we actually measuring? Like, where are we actually measuring it?
In the serum?
Yeah, we're actually measuring it from their blood. You do venipuncture, you draw some blood, and then you're looking at it in the blood. But again, these are only supposed to be found inside of cells. So Claudia, so AST and ALT. So if these are elevated on a serum test, what does this indicate?
Cellular damage?
Exactly. So this is one of those things that really confused me when I was a medical student. It was like, oh, we're measuring these enzymes. So I was like, so there's more enzyme activity in the blood? I don't understand. It's actually much more simple than that. And as Claudia very, very clearly pointed out, there's damage. If there's damage to these cells, then the enzymes, the AST, ALT that would normally be there, are now suddenly found inside of the blood. So if you have usually liver damage, right? So if I have liver damage, then the AST and the ALT from inside of the liver cells will now spill out because I've got cell necrosis or damage, and it'll be in the blood. And so when I measure it in the blood, it won't be elevated. This is basically the same idea behind measuring just about any enzymes that we measure in the blood, like troponin, CK, right? All that stuff. Same idea. LDH. So Paula, so alkaline phosphatase, right? What organs release the majority of it? Saba?
Is it the bone and gallbladder?
Oh, pretty much. Not necessarily gallbladder. It's actually liver, which I was actually surprised with. I actually didn't realize. I had to look this up. I was like, I wanted to make sure. But it's actually liver, which is interesting. I actually didn't know that. But bone, yeah. So bone and liver. So you can also, just for your knowledge, it's also released from the placenta. So sometimes on questions, you'll have some pregnant women in the first trimester, and she'll have high alkaline phosphatase. You should still probably check a GGTP just to check, but it's probably from the placenta oftentimes. So yeah. So what role is it thought to play, Jay? Do you happen to know what role it's thought to play in bone? I don't think I knew this at your stage.
I know it's released if there's bone breakdown.
Interestingly, it's actually released when there's bone buildup. It's actually thought to have a role in normal bone mineralization. So phosphatase will cleave pyrophosphate, which is a complex thing, but pyrophosphate generally will inhibit bone. So it destroys an inhibitor of bone formation. So it's a double negative, right? So it destroys an inhibitor. So it inhibits the inhibitor, so it causes bone mineralization. thought to be. No one. The funny thing is that no one actually knows what alkaline phosphatase is used for. I spent a lot of time looking, but everywhere I looked, they said we don't actually know what most of these alkaline phosphatases are doing. I was like, oh. So Miriam D. So use the proposed role in bone to explain what bone conditions it's elevated in.
Anytime you have bone turnover, so I would say osteoporosis, osteomalacia.
So close. You are correct about the osteomalacia. So vitamin D deficiency, right? So kids are osteomalacia, right? It's not, you don't really see an osteoporosis so much. But anytime that you are actively making bone or you are trying to make bone. So vitamin D deficiency, you're not, sorry?
Like not in when you're losing bone density.
You would not see an increase in alkaline phosphatase if you're losing bone. But if your body is making bone or trying to make bone, so if you're making bone like Paget's, you see an increase in bone. Vitamin D deficiency, you're not necessarily seeing an increase in bone formation, but it's like your body's trying to make more bone. That's why they say they have more osteoid, right? The osteoid is basically just like the collagen. So you are trying to lay down all that collagen and you're trying to mineralize it. You just don't have the calcium and phosphate to actually mineralize it. But you're trying to, right? Which is why your alkaline phosphatase is increased. Cool?
Yep.
Yeah. Again, interestingly, we don't really know what alkaline phosphatases are supposed to do in most cases. We've got an idea in bone, but that's about it. For the liver, just, I don't know. It's funny. We don't actually know what the kidneys are filtering out that's so bad. We know that it correlates with having high creatinine and urea, but it's not your creatinine and urea that are bad. So interesting how much and how little we know about medicine all at the same time. So Rosa, so alkaline phosphatase. So elevated levels indicate what in the liver? Why is this thought to occur?
The liver, would it be production? No, I really don't know.
Yeah. So, sorry, Saba asked the question. She said, would you also see elevated alkaline phosphatase in prostate cancer mets? I think so, yeah, because prostate cancer, I believe, is osteoblastic. So if you're making more bone, then yes. But to return to Rosa's point, so elevated, so interestingly enough, so biliary obstruction, the thing that you must know, the thing that you have to understand is that biliary obstruction leads to an increase in alkaline phosphatase. So I thought for the longest time that this was because alkaline phosphatase spills into the blood, that you block the biliary tract. And so just like bilirubin, right, you conjugated bilirubin that basically spills into the bloodstream. I thought that the same thing was happening with alkaline phosphatase, that somehow there was alkaline phosphatase within the lumen of the biliary tract and that it would leak into the bloodstream. It turns out that's actually not true. That's actually not the reason. The reason is because you increase synthesis of it anytime you have biliary obstruction for reasons that are beyond me. I do not know why. But yeah, it's actually because of increase in synthesis. Because I think that's important. It's an important distinction to make because, again, you would think if it was something that was, again, it's found in liver cells. So you would think that any time that you had damage to liver, you would also see an increase in alkaline phosphatase. But that's not really true to the extent that you'd think, right? You would think that AST and ALT and alkaline phosphatase should all increase by the same degree if you had liver damage, like hepatitis. But that's not actually true. AST and ALT go up much more than alkaline phosphatase does.
Alec, one question. The normal levels for AST and ALT would indicate just the turnover of the hepatocytes, like the normal
damage to the cell membrane of hepatocytes, therefore allowing like usually necrosis, right? But damage in general to hepatocytes. And so release of AST and ALT into the bloodstream.
If there is something that is causing major damage, then that's when we see the levels like substantially increase.
Yes, exactly. Yeah. So like usually it'd be like really bad hepatitis or shock liver where you get like ischemia to the liver for a long time, or acetaminophen toxicity, like really bad Tylenol toxicity to the liver. Yeah, those are the classic ones. Yeah, but it makes sense. Whereas alkaline phosphatase, again, sorry, I'm getting ahead of myself. So Shama, so if you see an elevation in alk phos, what test should you order next and why?
You would get a GGT to check if it is from the bone or just the biliary tract, liver actually.
Yeah, exactly. GGT. I don't know what's GTTP, transferase. I don't know, because sometimes it's written as GTTP, but I don't know where the P comes from, in fairness. So it's more specifically, so GTTP is found more in the biliary obstruction rather than elevation for other things. So exactly. If you're trying to differentiate between bone or like placenta, so like in a pregnant woman, you're going to see an increase in alk phos. You should probably still check a GTTP just to see if they're having biliary obstruction or if it's just because of the placenta. Cool. All right, Leah. we are back to you. So in our Joubert patient, explain the AST, ALT, and alk phos.
In alcoholics or patients who drink a lot, why is the GGT elevated in isolation?
I don't know. I looked for that. I don't know. It's a great question. It is true, GGTP is elevated in alcoholic patients, but I don't know why. If you find it, though, I have faith, Matan, that you'll find it. If you find it, you tell me. All right, Leah. So in our Joubert patient, explain the AST, the ALT, and the alk phos.
So the alk phos 40, I think, is within the normal range. And I think for the AST and the ALT 20 and 21, those are both within the normal ranges as well. So the Gilbert patient he's born with the condition, and you're not having any sort of injury to the hepatocytes like we were talking about. So your AST and ALT wouldn't be expected to rise. And the alk phos also, the liver isn't, so when you're not having any bone issues and your liver is not being injured, I guess I would say. So same thing.
Again, this is why I know it sounds silly that like you should learn why alk phos is elevated, but it's even though it's in hepatocytes, the reason why it's elevated is not because of liver damage. Usually when it's elevated a lot, like when it's disproportionately elevated, it's not because of liver damage. Why is it? Under what circumstances is alk phos disproportionately elevated? Biliary obstruction. So you wouldn't expect, that's not a biliary obstruction problem, so your alk phos isn't elevated. So I loved your reasoning, right? You were like, it's a problem with conjugation. So you wouldn't expect the AST and the ALT to be elevated. That's great. But also remember that the alk phos wouldn't be elevated. You could use similar reasoning, but really the reasoning that I think would be more precise is to say you don't have biliary obstruction, therefore biliary obstruction or bone formation or the placenta. So you don't have alk phos elevated. That was good. Yeah.
I have a random question too, just about the alk phos. You said, I know the placenta thing, I've seen that before in questions, is if you have a teenager or something, I've never seen that in a question, but if they're like growing a lot, does that?
Oh, great question. Yeah, actually, in my reading of this, apparently children can have elevated alk phos. Yeah, like kids. I don't know about maybe. Oh, you mean someone going through a growth spurt? Presumably, yeah. I don't know.
I just hadn't seen that before, but I
No, it's a great point. Yeah, it's funny because I was reading. I was like, yeah, if you Google it, you're like, oh yeah, oh interesting. Like they'll list the populations in which you see it normally. But yeah, children are one of them. Matan?
Patients with fractures as well, right?
Yes, I think so. Yeah, because again, you're building bone. Yeah, it's pretty cool. I know. Yeah, it is valuable to learn why. I know that in medical school they don't teach us this, but it is valuable because then you can basically predict, which is great, Leah. That was fantastic. It was such a good question, right? Because that's exactly the kind of reasoning that you want to have, both on tests, but also just in life and in your clinical practice, because it would make sense. Just makes total sense. All right, so Fong. So LFTs, use what is measured to explain why the LFT, the liver function test, is actually a misnomer. Miss is wrong, or I think bad. Nomer is namer, right? Nome is name. So why is it improper to call LFTs like liver function tests?
I don't know the answer. The liver function test is to test the liver function, yes, and the AST, ALT, and they are about.
Is that testing your liver function though? AST and ALT. Like, what about your function is that testing?
The other liver function include like synthesis and.
Yeah, exactly. And so AST and ALT, does that give you a measure of their synthesis, their synthetic? No. Alk phos, does that really give you a sense of their synthetic ability? No. Bilirubin, maybe. I guess I could be convinced that bilirubin, because making direct bilirubin, sure, is the measure of their liver's function, but it doesn't really tell you, it's not really telling you about their liver function. So I'm not the first person to point this out, but calling them liver function is wrong, right? Because they're not really a measure of liver function. Certainly not of the liver function that we care about, which is that we follow most carefully, which is their synthetic function. So Satya, so what is measured instead? If we wanted to measure someone's synthetic liver function, how would we actually do it?
Synthetic liver function. That means not the excretion part.
Exactly. Synthetic meaning making stuff. So how would we measure our proteins, our liver's ability
to make protein? For example, I don't know if ALT should count.
Because again, it's elevated. So yeah, no, that would be not a great measure of liver function. Sure, you make it in the liver, but if it's in a hepatitis C patient who is like a failing liver, you couldn't really follow their ALT.
I was going to ask if PT or INR could be followed.
Yeah, perfect. That is one of them. PT and INR is one of them. Great. And then Rosa, what's the other one?
I said albumin.
Yep, you got it. Yes, exactly. So it's those two are the major ones. So albumin is one, and then PT is the other. And so let us go to IO. So albumin is made in the liver, right? And so most coagulation factors are also made in the liver. And so again, if you have low synthetic function, you're going to have your coagulation factors are going to go down, and so your PT is going to be elevated. So if you actually want to look at, so these are the ones that we actually use. So if you want to test someone's synthetic function, the classic ones to measure are PT and serum albumin. And gosh, we run IO. In liver failure, what's affected first? The serum albumin levels or the PT?
I want to say the albumin.
And try again.
PT?
PT is affected first. Do you happen to know why?
Because if there's a decrease in the function, then there won't be production of the proteins, which is one of the proteins that it produces is the protropin. So
True. Although, so the answer actually has to do with half-life. So what has a longer half-life, do you think? All of the coagulation factors or albumin?
Albumin, I want to say albumin has a longer half-life, but yeah.
So if I were to stop making all proteins, what levels are going to decrease first? The
coagulation factors will decrease first.
Exactly. Yeah. So PT is affected first. That is because factor 7 in particular has a very short half-life, somewhere in the order of 3 to 6 hours. So in other words, if I stopped making proteins, my factor 7 levels within 5 hours would be half. And then within 10 hours, 6 to 12 hours, they would be like a quarter. So that's very quick. So within a day, I would have basically no very little factor 7. It takes about 5 half-lives to get to 5 half-lives to basically reach steady state or to have something clear from your body, be completely cleared.
Really quickly, is this why we would use PT instead of PTT? PT?
Yeah, yes, because PT is affected first. I presume that your PTT would also be affected, but yeah, the reason why I use PT is because factor 7 has the shortest half-life of all of them, or at least my understanding. As opposed to albumin, as IO pointed out, albumin has a very long half-life. So again, 5 half-lives to go from 100% to 0, or to go from 0 to 100%. That's like semi-common pharm question for step 1. So it would only take about 15 hours to get to near 0 levels for factor 12, like less than a day. But for albumin, 5 half-lives is like 100 days. That's almost 3.5 months. So if the liver stopped making albumin, the levels wouldn't fall for a while. Cool? All right. So Matan, so acute versus chronic liver failure. So what lab values would you measure to differentiate between the two? And how would you use the results to differentiate between them?
Let me think. So you do your AST and ALT. The ratio of the two helps you differentiate between acute and chronic, and specifically some of the causes of acute. I just can't remember the ratios offhand.
I think you're thinking like alcoholic versus viral hepatitis.
I am, and I know chronic fits in somewhere between the ratio of 1 and 2.
Yeah, so maybe I don't think I'm asking the question very well. If you were actually to differentiate between like synthetic failure, because again, remember liver failure and because the LFTs, although they are called liver function tests, aren't really telling you about the liver function. They're really just telling you about liver damage or bilirubin, right? / bilirubin production and conjugation. So like they're not really telling you about function. So liver failure isn't defined by a certain AST or ALT value. Liver failure is actually defined partially by synthetic function.
Yeah. So then I would use the clotting factors or PT-INR and albumin levels.
Great. And so how would you differentiate? So what would they, if it was acute liver failure, what would be abnormal versus chronic? What would be abnormal?
Given the half-lives, you'd probably have a normal albumin level and an elevated PT-INR level.
In which?
And chronic, both be deranged.
Perfect. Yeah, exactly. And that's exactly what you're supposed to do. Yeah. So you'd measure the serum albumin in PT. In acute liver failure, your serum albumin would be normal because it's got a really long, like weeks. Versus PT would be up because again, if your liver stopped making coagulation factors, right, your factor 7 levels would fall basically in a day within like 12 hours. Versus chronic liver failure, that would be enough time. So if it was now weeks to months, your serum albumin would be much lower, as well as your PT would still be high. Your PT would be high in both cases, but your albumin would be normal in acute liver failure because it hasn't had time to fall, versus in chronic liver failure, it would be low. Cool? Perfect. These are the things that I wish that I had known. And again, they're not that hard. They're really they're really not that. So we are back at our vignette. So what I want you guys to do is, again, revise your pathophysiological chronology in the next couple minutes, and we will talk about it again and wrap up. All right, cool. So I want to do something a little different for this one. So instead of telling you my pathophysiological chronology, I'm basically going to read this question as if I was reading it for like real. So just to give you a sense of what the sentence by sentence analysis would look like for this question. So we've got a 15-year-old boy comes to his physician for nausea and vomiting for the past 2 days after school potluck. So we can assume that he probably got sick from the potluck, but that would be my guess. So pretty nonspecific, probably. Several of his classmates and teachers reported similar symptoms. So definitely something. So definitely some sort of foodborne illness from the potluck. It's usually the potato salad, whatever has got like dairy. Temperature is normal, blood pressure is normal, and pulse is normal. So in other words, he's had nausea and vomiting, but it's not so bad that he's like, that his heart rate, because again, his heart rate would be high first. So the real big one is that his heart rate is normal. On exam, there's mild scleral icterus. So now you're thinking like, so he's got nausea, vomiting. So you would be thinking, this is at the time, because up until this point, obviously you have no clue that this would be like GFR, but this would be the first clue. Scleral icterus, so he's got jaundice. So you're thinking, honestly, you might be thinking hepatitis. So I probably would have been thinking hepatitis. It's like hepatitis, maybe. And so abdomen is soft, non-tender, and mildly distended. So pretty non-specific. Soft, non-tender tells you it's not. We weren't really thinking hid peritoneal signs. And mildly distended, probably just because of his nausea. I don't know. That's not specific. So the labs are really the key here. So in this case, he's got high bilirubin, but his direct is low. And his alk phos, his AST, and his ALT are all normal. So that tells you that this can't be hepatitis. So we'll learn about how to recognize the different patterns of basically bilirubin or LFT abnormalities in general, but this would be an isolated hyperbilirubinemia. So specifically an isolated unconjugated hyperbilirubinemia. So there's really not that many things like that. The big ones would be hemolysis, or would probably be the most common. So in this case it would be Gilbert, and yeah. So I guess in fairness, I probably should have included his hemoglobin in this in retrospect, because in fairness, this could be hemolysis. And yeah, it'd be hard to tie that in with the potluck, but you couldn't eliminate hemolysis by these labs, because hemolysis would also look like this in terms of the labs. So cool. And so my pathophysiological chronology we already talked about. This is what it would be. And so any questions about that, about my analysis of that? Or you're like, nah, like that was not very good. This is how I would have analyzed it.
Dr. Palmerton, I'm a little confused about how several of his classmates and teachers reported similar symptoms.
The same bad thing.
But then are we to assume that they all have Gilbert syndrome?
Oh, sorry. Oh, I see. Oh, great question. By similar symptoms, I meant that they all were nauseous and vomited, not that they all had jaundice. That is a fair question. The sequence, though, is, yeah, similar symptoms, because we didn't hear about the jaundice until the fourth sentence question.
Yeah, and what you said made sense, like syntactically.
But it's a very good question. Yeah, I should have made that more clear. Reported similar. Yeah, that's a good question. Yeah, this is why I like to do this, because yeah, I can see. Oh yeah, probably would have added the hemoglobin. Probably should have added.
On that, I have a question. But what if you have some type of like a DIC or some type of with some bacteria creating exotoxins that would cause a type of intravascular hemolysis? Would this be?
But he'd be a lot sicker. DIC, to be that sick, you'd be a lot sicker. Like autoimmune hemolytic anemia would be the other one. It's a little bit less likely, but that would be the other one that I think would be possible. Would be autoimmune hemolytic. So in other words, to get that question correct, you would have had to have looked at the answer choices and determined hemolytic anemia. Doesn't make sense.
Why would he have been asymptomatic until the potluck?
Because he'd never had that kind of stressor before. Because there has to be some kind of stressor. So that's why it's like classically like a college student that's like pulling all-nighters, because you've never put that much stress on your body. Right?
Okay.
It's like different
and so we assume that the liver experiences that stress, and then in response, it just really just stops. Like the UDP glucuronidase just got it.
Great question.
Thank you.
Other questions?
May I ask one question?
Of course.
How is this different from hemolytic uremic syndrome?
HUS? Oh,
Yes.
Could this be HUS? Yeah, I guess. Because the problem is that nausea and vomiting are very nonspecific, right? So someone eats something, they get nausea and vomiting, and then, yeah. So I guess in theory it could, but they would be a lot more sick. HUS is, they get, like, the whole point of these labs is that it's like his vitals are normal. He's only got very mild icterus. He's otherwise just pretty well. He's just got little yellow eyes. That's classically how Gilbert is going to present. They shouldn't have really many other symptoms. But yeah, like HUS, you'd be a lot more sick. And yeah, because again, like HUS, classically, you'll get like neurologic problems, and you get kidney problems, and you'll get hemolytic anemia and thrombocytopenia and a number of things. That's the classic pentat. Oh, this is fun. Oh, I like this. I don't know how you guys felt. I've been thinking about doing this, of just, instead of just rereading the question, just read it as if I was like taking the test. But this is, I think, could be.
Yeah, that was really helpful to hear your thoughts as you were reading each, I guess, symptom.
Cool. Yeah, I think I'll do that because it doesn't take that much more time. So Marissa says yes, very useful, as does Sujith. Great, awesome. We are back to our summary of key concepts. Again, I won't reread it, but it's fun, right? It's fun to think that something so simple like a porphyrin ring in heme can be tied to jaundice and bilirubin, right? There can be tied to the color of your urine if you have cholestasis, if you have biliary bile stuff. Right? It can be tied to the color of urine, just period, because of the urobilin. It can be tied to the color of your poop being brown, or the color of your poop being clay colored if you have no bilirubin getting into your stool. You can tie it to the color of your sputum. Your sputum, if you've got bacterial pneumonia versus if it's clear, if you've got viral pneumonia or just pus in general, right? The green color of all the wonderful green things in spring and summer. It's pretty cool. It's all very similar. Joubert we talked about basically is a way of talking about all these things. And then we talked a lot about LFTs, right? Alk Phos, and how you can use the fact that it's increased in bone production to explain various things like why would you see it in like children that are undergoing a lot of bone growth or in fractures or in biliary obstruction or all of these things. You can explain it. Why is AST and ALT higher in really bad liver damage? All these things. It all has a logical basis. So thank you so much for this. And yeah, I'm looking forward to next time. We're going to talk next time. About more about this. And yeah, we'll talk about, it's actually about Coombs. So hemolytic.
Alec, before you go,
yeah, please.
There's another disease. I think it's Crigler-Najjar or one of those.
Yeah, so Crigler, I don't know how to pronounce it. So Crigler-Najjar is where it's basically a really extreme form of where you basically have no or extremely low UDP glucuronol transferase function. So they present basically at birth, and it may not even be compatible with life depending on how severe it is.
Cool.
Yeah. Satya asks, can we do more PCs? That's super helpful. What do you mean by PCs?
The pathophysiological chronology. It's just helpful to think how you're thinking.
Oh, yeah. Oh, every single time we do, this is what we end with, is the pathophysiological chronology. So
cool. Thank you.
Glad. Yeah, absolutely. All right, guys. Any other questions, thoughts, concerns?
I have one more question. How do we get from, I guess, the GI bug, the gastric stress, to the low activity of UDP? We already know he has low activity of the UDP gluconol transferase. Is it an elevation in bilirubin that causes that decreased conjugation to be a problem? What is in between gastric stress?
No, it's actually the stress itself causes the UDP glucuronol transferase activity to go down.
So your baseline bilirubin is...
So normally like you have enough. So in other words, you have enough UDP glucuronol transferase activity without stress that you can conjugate all the bilirubin that you produce, or a normal amount of bilirubin. Okay. It's just that in Gilbert, because I think under normal circumstances, UDP glucuronol transferase activity decreases. And so Gilbert, they have like slightly decreased levels. You can think of it as they have slightly decreased levels at birth. So normally that doesn't cause a problem. However, when you get stressed and your UDP glucuronol transferase activity decreases even more, now it suddenly becomes a problem. Now you do not have enough activity.
How does that explain the total increase in bilirubin?
Because you can't conjugate it. So because you can't conjugate it, you can't eliminate it.
Sorry, yeah, that makes sense.
Cool.
Got it.
Oh,
yeah.
Great question. Fantastic question. Yeah. I don't think I did not make that clear. So yeah, cool.
I have a question to follow just that up. You said you can excrete the bilirubin that's just formed. Wouldn't that go as bilirubin and just be out? Because I would think either it's conjugated or it's unconjugated. So if I'm not able to conjugate it, then the unconjugated bilirubin should just be absorbed through my intestine.
Yeah, exactly.
So then I will...
your bloodstream. Or it wouldn't even make it into your GI tract in the first place, presumably.
Oh,
right.
Yes.
If it's not conjugated, remember, like in general, things that are nonpolar are absorbed pretty well. Things that are polar are not. So morphine is very polar. It's like you have to take many times the amount of morphine orally as you would get, because oral morphine is not absorbed well because it's very polar. Fentanyl is very nonpolar. Fentanyl IV and oral are like very similar in terms of their overall effect. That's why they make like fentanyl patches. That's why they make fentanyl lollipops, because you can absorb it really well. So we are going to restart our discussion of renal pathophysiologic chronologies. I hope that this one is better than the last time that we tried this. I want you guys to give me honest feedback though. So we're going to show you the vignette and I'm going to read it slowly, like I always do, and I'm going to have you guys write the pathophysiologic chronology. Okay, so a 58-year-old man comes into the physician for a pre-employment checkup. He reports having not seen a physician in 20 years. His temperature is 36.5 Celsius. Heart rate is 70 per minute. Blood pressure is 160/95. And respiratory rate is 15 per minute. His labs are significant for a serum creatinine of 3.5 milligrams per deciliter, blood urea nitrogen of 40 milligrams per deciliter, serum sodium is 140 milliequivalents per liter, and serum potassium of 4.5 milliequivalents per liter. What is the pathophysiologic chronology? Is his serum sodium normal? Why would this make sense? Are his serum creatinine and BUN normal? Why would this make sense? How can you relate the serum creatinine with his blood pressure? So in the session document, I want you guys to write what you think the pathophysiologic chronology is, and we'll talk about it. All right, this actually looks pretty good. And I was watching you guys type out your pathophysiologic chronology, but these are pretty good. I can tell that many of you guys have reviewed renal since the last time we talked. That's great. Perfect. Okay, so what I'm going to do is I'm going to walk you through my summary first of what I would say is happening. And then, again, isn't the only explanation of what this might be. Some of you guys have renal artery stenosis, which is possible. So that would actually be one way of explaining this. But I think the simpler explanation is just to say that hypertensive diabetes, right? So things that would just, those are things that cause chronic kidney failure, right? So the most common thing would just be that he just has kidney failure. So kidney failure means you have a decrease in filtration. Decrease in filtration means you're going to accumulate things that you would otherwise normally filter or eliminate, right? So creatinine, BUN, sodium. That will give you hypertension because retention of sodium is going to cause retention of water. It's going to increase your intravascular volume, causing hypertension and high serum creatinine. Okay, so this is a pretty simple vignette, but the basic ideas behind it show up all the time in renal. And if you don't really understand the connections between them, it becomes a lot harder for you to get those questions right. Not impossible, but it makes it a lot harder. So understanding the individual elements will help you get more questions right. And so that's what I want to go over today. So let's start from the top. Alexa, I saw you were talking about breakdown products, so this is great. But before we talk about creatinine, I want you to tell me, what is creatine? What is creatine used for in the body?
Creatine, isn't that used? I want to say it's like a breakdown product of ATP. But
You're saying one of the words is right. So it is not a breakdown product of ATP. It's actually like ATP. All right, so ATP is adenosine triphosphate. So there's adenosine, the base that we use in DNA. TP is triphosphate. So there's three phosphates, each of which is high energy, which we'll leave it at that for now. Right, so high energy. So it's that high energy phosphate bond that really is like what carries the energy, so to speak, for ATP. But you can also have high energy phosphate bonds in other things, namely creatine. So creatine is basically like ATP, just instead of having three high energy phosphate bonds, it only has one. That's the same idea. Does that make sense?
Yeah.
It's not really breakdown, right? It's a different like molecule, but yeah, same idea. So Boogie, so what adds the phosphate to creatine? What enzyme?
I'm not sure what is adding the phosphate to.
Great. Well, but this is one of those things that you can use your wonderful reasoning sounds for. So what's the name of an enzyme that adds phosphate to something? It's a kinase. A kinase.
Yes, kinase. It slipped my first.
Okay. So what enzyme would add a phosphate to creatine?
Adenosine kinase.
Yeah, creatine kinase. Great. So Danielle, so what's the difference between creatine and creatinine? Or how about Deb? Deb, can you tell us the difference between creatine and creatinine?
Creatine is an energy source, whereas creatinine is like a breakdown product of muscles. So they're not like creatinine isn't used for energy.
Kind of. So creatinine is a breakdown product of creatine.
Okay.
Creatine just breaks down into creatinine. Right? Some things just like spontaneously decompose. It's essentially what creatine becomes when it breaks down. It becomes creatinine. You know, if I've got 100 creatine molecules, some fraction of them are going to be turning into creatinine every hour. Let's just orient ourselves to what creatine does and what creatinine is and why we use it. So, right? This is a muscle, right? Very nice looking muscle. This is a blood vessel, right? So creatine, CK, so CK stands for creatine kinase. So kinases phosphorylate things. So creatine becomes creatine phosphate. And then the phosphate is used, remember in ATP, right? The phosphate is used to cock the myosin head when you're talking about actin and myosin interactions. So ATP, right? Same thing, right? The phosphate in ATP is used, same idea, but because it's a carrier of a high energy phosphate bond. So creatine becomes creatinine, and that creatinine basically goes into the bloodstream and then is carried to the kidneys where it's eliminated. Pretty simple, super simple. So Deb, using the function of creatine kinase, I want you to explain when we would see it elevated in the blood. Why do we use it?
During muscle contraction?
Not muscle contraction, right? Because it's an enzyme. So think about it. It is an enzyme that is inside the muscle. In other words, when would the enzyme, instead of being inside the muscle, be outside of the muscle and measurable in the blood?
So muscle breakdown, muscle necrosis.
Muscle necrosis, muscle breakdown, right? So CK phosphorylates creatine to create high energy phosphate bonds. We already talked about this. So this is found primarily in muscle. So if CK is elevated, it indicates some sort of necrosis or damage in muscles. So Jared, so in rhabdo, right, the breakdown of muscles, what electrolyte abnormalities do you expect to see, and what classic enzyme would be elevated in the blood?
You'd probably see elevated creatine kinase, probably see elevated creatinine because it's the breakdown product.
Not really creatinine. You'll see elevated creatinine for another reason that is just because creatine or myoglobin will damage kidneys and decrease filtration of creatinine. But I don't think it's because the muscle broke down. I think it's because your kidneys failed.
Okay.
But what electrolyte is high? What ion?
Sodium, because it's usually inside the cell and gets pumped.
Is that true?
No. I'm trying to remember which way the sodium potassium pump moves.
Yeah. Well, just think about it. So again, remember, you need strong foundation, you need good question interpretation. So strong foundation means you have good factual knowledge, which is kind of where this is, but I would argue that this isn't an integration gap. So think about normal sodium levels in your blood. What's the normal sodium level in your blood?
Like low 140s.
140. Let's just say 140 and call it a day. Like it's so much easier to remember one number than like a range. So let's just say 140. Okay. What's the normal potassium level in your blood?
4.
4, exactly. Which is higher?
Sodium. So
which is the one that's outside the cells?
So sodium's outside. So potassium will move out when you rupture the cell. So potassium will be high.
Boom. See? So now we've moved from factual knowledge to integrated knowledge. And see how much more useful that is, both in like a stressful, oh my gosh, like I'm being called on kind of situation, but also I'm in a test and I need to know this to answer the question kind of situation. What are your thoughts?
I feel like it's one of those things where like in the test, I feel maybe a little less pressure to have just instantly, but at the same time, there's an equal chance that I would just like out of a gut feeling do it and then not think about it as much.
Yeah, totally. You would be one of the few people that wouldn't feel nervous on a test and rush through. So I'd be impressed. I get nervous in those sorts of situations. So it really helps the more I've integrated it. So that was wonderful. Yeah, because again, what's high in your serum, you probably haven't thought about integrating that with the sodium potassium ATPase, but that's exactly why. That's why your sodium is 140 and why your blood potassium is 4. Sodium potassium ATPase, right? Because 98% of all of your total body potassium is inside the cells. So it's like 160. It ends up being 160 millimolar, right? So it's literally 40 times your serum concentration, your extracellular concentration. And what's crazy is that muscle contains 80% of the intracellular potassium. I didn't know that. I didn't know that muscle contains so much of it. So in other words, of all of the potassium, more than about 80% is in your muscles. So I never really thought like that would be why your potassium, but yeah, that's why your potassium goes up by so much in your abdomen. Cool. So when muscles break down, you see CK and potassium. You'll see other things too, but those are oftentimes just a product of like downstream problems, like your creatinine will go up because of myoglobinuria. All right, so this is the story, right? So as Deb pointed out, creatine kinase should only be inside the muscle and should be inside the cell, not in your bloodstream. So if we have something like rhabdo and our muscle breaks down, then we're going to have a bunch of potassium, right? Because our potassium is really high in the muscle, and we're going to have the creatine kinase also get into a bloodstream, and we will be able to detect it on a blood draw, right? Because normally you shouldn't see such high potassium levels because most of it's in your muscle. And normally we shouldn't see creatine kinase because it should be inside your muscle, not outside of it. So Mohana, so what do the kidneys control, or how do the kidneys control the amount of substances in our blood, like in a general sense?
the kidney control the substance by reabsorbing or secreting into the urine.
Exactly. And in addition to that, it filters, right? So some things are filtered, some are not, right? Some things are secreted, some are not. Some things are reabsorbed, some are not, right? And you can titrate the amount of secretion and reabsorption. It's pretty amazing, pretty amazing. So Paul's asking, would you also see elevated calcium? Probably not, because again, the majority of the calcium, like there's like a 40-fold difference between intracellular potassium and extracellular potassium, which is roughly the same for like sodium. It's like a 400-fold difference. It's like an order of magnitude difference for calcium, because most of the calcium's outside of the cell, it's not inside. So if you get rhabdo, you shouldn't see high calcium. Yeah, it doesn't. Your calcium's already outside the cells. So breaking down muscles, there's not a lot of, I guess there's some, right? Because there's the sarcoplasmic reticulum, but not as much as is outside. So I don't think so. I don't think you see a really high calcium. But he's asking, would you see a spike in potassium as well in an MI, or only CKMB? You might see a little bit, but remember, like your heart muscle, in terms of the number of cells, the amount of potassium that's like inside your heart is probably not that much overall, right? If 78% of all of your potassium is inside your muscle represents only, I don't know, a fraction of all the muscle in your body. So if it was a really massive MI and took out your entire heart, maybe, but then you'd have a lot more problems than just spike in potassium. So probably not. Yeah, I think it'd mainly be CKMB. Okay, but yeah, so kidneys control the amount of substances by filtration, secretion, and reabsorption. So filtration. So Nathan, like, how do the kidneys filter? What do they filter through?
Like Bowman space?
Yeah, exactly. Well, it filters it to Bowman space, but it's through the glomerulus, right? Your glomerulus is basically like a sieve. That's what I'm going to argue. It's a lot easier just to think about it as a sieve. So Nitin, where are the things filtering from? Nathan's already kind of answered the second part, right? Where are they filtered to? So where are they coming from, and where are you going to filter them to?
So they are filtered from the afferent arteriole and to the efferent arteriole. Loop of the proximal convoluted tubule, loop of Henle DCT.
Sure, but before it gets to the proximal convoluted tubule, where does it go?
Glomerulus.
Yeah, what's through the glomerulus? It goes actually technically.
Okay, yeah.
The afferent arteriole isn't really where it's being filtered from. Technically, it's coming from the capillary, but you're right in that like the capillary blood is coming from the afferent arteriole. But I want you to think of what is immediately before the glomerulus and what is immediately afterwards. It's the exercise that I wanted. So basically, you can think about this is that you've got your sieve, right? Your little mesh, which is your glomerular basement membrane. And before it, you got the glomerulocapillary, and after it, you got Bowman space. Pretty much it. Paul, can you tell us what determines what things are filtered through the glomerulus? Like generally, what are the things that'll determine whether something gets filtered or not? What do you think, Paul? Oh, Paul answered. He said, the charges associated with the molecules and size. Very good. Yeah, exactly. It's basically charge and size. That's it. So things that are smaller, more easily be filtered through. Things that are uncharged, certainly. I think it's positive things get through easier than negatives. Because I think that's like how albumin gets filtered out, is that I think it's negative charge. But yeah, it's charge and size. So Paula, is creatinine filtered through?
Oh, I want to say no because of its charge. Is it charge?
It is uncharged.
Oh, but then because of its size.
So creatinine is filtered through.
Okay. Oh, it's not reabsorbed.
Correct. Yes, that is a critical point. Yes, it will make it through. So creatinine will make it through to Bowman space. If it didn't, you would be useless to us, and it would just accumulate in our blood, and we would just be full of creatinine. Yeah. So how about protein? Paula, is protein filtered through?
Protein is not.
Very good. Yeah, generally it's not. Right. So if I've got protein, generally speaking, it does not filter through the glomerulus. So creatinine makes it through. I key out creatinine, but I normally, right, outside of nephrotic syndrome or certain kidney problems, shouldn't be peeing out protein because it shouldn't be filtered through. It should stay in the blood. Cool, make sense? Because what we're building towards is the idea of why does creatinine increase when you have kidney failure? This is it, basically, because it doesn't get filtered. That's going to be the punchline. So just to give you an idea of what we're building towards. Okay, so Priyanka, generally speaking, what is filtered through the kidney?
Is this talking about like after the glomerulus?
Yeah.
That's
a tight question.
Sorry.
It's basically
Sorry,
it's like a remembering question. So let me give you another question. Basically, most things except for protein, generally speaking. So what are the things that we would want to keep that are filtered through the glomerulus, right? There are some things that we want, right? Like we need sodium, we want potassium. How do we make sure that we don't lose it? Because those things get filtered through.
Would that be with our like the channels that are in the proximal?
Sure, but in a general sense, what are those channels in the proximal tubule doing?
They're reabsorbing.
Yeah, exactly. It sounds pretty simple, and it is very simple, right? If I filter something, but I still want it, I need it, right? I'm like, I need that sodium, give it back. So I reabsorb it. I'm like, oh, I need that potassium, give it back. You reabsorb it because you end up, so let's say that you had 100, you're going to filter 100 molecules of sodium, right? Priyanka, how many of them are you going to reabsorb?
Not all of it, but I know like most of it. I'm not sure exactly how much it was.
60%, 70%, 80, 90, 99, what?
I would say most of it, so probably like 80.
It's like 99.
I'm totally guessing.
99%. Yeah, 99%. The way to know that is that it's the opposite of FeNA. We'll talk about this later, but it's the opposite of FeNA, right? So FeNA, right, is how of all the stuff that's filtered through, how much is lost, how much is the fractional excretion of sodium, how much is lost. So if the FeNA is 1%, means I've reabsorbed 99% and I've lost 1%. That's pretty normal, FeNA of 1%. So yeah, most of it. So if I filter something through and I still want it, I need to reabsorb it. And we reabsorb a ton of stuff. The kidneys are pretty brilliant. So Sujith, why would we want to secrete things? Why would that make sense?
Maybe there's some excess that's not in bodies, so just kind of
exactly. Like in a general sense, I reabsorb things because I want to keep it. I secrete things if I don't want it. Pretty simple, but exactly what you said. Yeah, maybe I've got a little bit too much. I need to get rid of it. Yeah, totally. So let's talk about glucose as an example, right? So Susanna, I want you to tell me, based on the size and charge of glucose, is it filtered? And if so, what happens next? Or if it's not, what happens next?
Oh, yeah, I think it's filtered until at the extent when it saturates the transporters, then, well, it's not filtered normally, sorry. And then when it saturates the transporter, well, it's filtered, but not, I don't know, I'm confused about myself. No, it's not filtered until it saturates the transporters. Oh, I was like, sorry, it's filtered, but it's, okay, it's filtered, but it's not reabsorbed. It's reabsorbed until it saturates like all the transporters, then it's not reabsorbed anymore, and you can find it in the urine. I think so. Sorry.
Yeah, so that was good. So it felt like putting you on the spot made it so that it was harder to integrate that knowledge. Like you had some factual knowledge, but it was harder to use it. Right?
Yeah, I was like, okay, what do I say?
It's something, but like this is bolded because I want you to make a part of this. So it's small and it's uncharged, so it's filtered. However, we want to keep it, right? If we lost all of our glucose in our urine, that would be pretty bad. It'd be pretty hypoglycemic. So we have to reabsorb it. So I've got my glomerulus, right? Represented by my sieve, right? By my mesh. And so I got glucose. It's going to go. And it filters through, right? Because it's uncharged and it's small. So it's going to go to the proximal tubule. And then in the proximal tubule gets reabsorbed. So what Susanna was talking about was that if I have too much glucose, right? If my blood glucose is too high, then what ends up happening is that I have so much glucose that it's going to saturate these transporters. I cannot reabsorb all of it. Therefore, some of it is going to stay in my urine, which is why my urine is going to taste sweet, which is why they call it diabetes mellitus. It's because in the olden days, they would taste people's urine. And because mel is honey in Greek, so they taste it. My daughter has this funny book. It's like not an encyclopedia. No, it's like essentially like a kid's encyclopedia for 4-year-olds. And it has like this really funny picture of like old people, like picture of people tasting urine. She's like, ew, that's gross. That's what you did. So that's why it's called diabetes insipidus, right? Diabetes is like you urinate a lot. And then insipid means like tasteless. So it doesn't taste like sweet. So it's tasteless. So they call it diabetes insipidus. As opposed to diabetes mellitus, right? Mel is honey. And so that's why they call it diabetes mellitus, right? Because you've saturated those transporters. That's why when, the guy that discovered insulin, right? The way that he figured it out, or as the story goes, is that like his dog that he'd taken out the pancreas in, he noticed that there were a bunch of flies hanging around the urine because the urine was sweet. So cool, yeah. So this is the parts of the kidney that reabsorb different things and what they reabsorb. So let's go back to Alexa. And Alexa, can you tell us where does the majority of reabsorption happen along the nephron? Just like in general. And then use this to explain what area is most sensitive to ischemia. because we want to integrate it, right? We don't want to just memorize it. We want to integrate it.
Yeah, so the majority of the reabsorption is going to happen at the proximal convoluted tubule. And because the PC2 is doing most of the work, it's the most vulnerable to ischemia.
Yeah, exactly. So the proximal tubule, right? So if they ever asked you, this is a not uncommon question on board exams, is the vast majority, or I'll say something like, most of X is absorbed where, right? Or something like that. If you guess the proximal tubule, you'll be right. I don't know, probably 95% of the time. Like, it's almost always right. That's almost always the right answer. And so it's important to know this for a couple of reasons. But one of them is that because so much stuff is reabsorbed in the proximal tubule, like even though sodium is absorbed, right, like at various places along the nephron, still the majority of sodium is still absorbed. Right? So this is important because it's very ATP dependent, because there's a ton of sodium potassium ATPases. So it needs lots of ATP. So it needs a constant supply of glucose. And so, right, it has glycogen. Actually, the reason why we have like clear cell carcinoma, like renal cell carcinoma, it's usually of the proximal tubule, or oftentimes it's of the proximal tubule. And it's clear because there's so much glycogen in fat, right? Because they just have such high energy requirements. And so if you have cancer of those cells, again, it's the same thing. You're going to have cancer cells that also have a lot of glycogen and fat. And so they're clear because when you dissolve all this stuff in this slide prep, glycogen and fat wash away. And so it looks white. It's white. But yeah, there's so many integrations that like of this concept, including that when you get ischemic ATN, which we'll talk about later, when you get ischemic ATN, you see the casts in the proximal tubule first, right? Because again, it's most susceptible to ischemia. And so when you have the ischemia and the cells slough off, they block up the proximal tubule first. Cool, isn't that cool? All right, I thought that was pretty cool. Okay, so let us go to Boogie. And Boogie, can you please tell us, what are the three major parts of an amino acid, generally speaking?
I thought it was the amine group and the phosphate group and then the rest.
Not a phosphate group, pretty close. So it's just think about the name, right? Like biochemistry.
Oh, sorry, carboxylic acid, sorry.
Right? It's the amino, right? So it's amine group, right? Acid group. And then there's the R group, right? The R group, the thing that's attached to this carbon. That's it. So Danielle, when you break down an amino acid, what waste product must you eliminate? Sort of a read my mind question, but it's important.
Nitrogen?
Yeah, exactly. Got to get rid of that nitrogen, specifically the ammonia that forms NH3, which can form ammonia. So Deb, why is ammonia bad for your body? Why is it so bad?
I know that ammonia accumulated in the body and like gets hepatic encephalopathy.
Good, right? So in other words, it can cause problems in your brain, right? Hepatic encephalopathy means that there's a problem with your liver. And specifically in that case, it's because you can't turn ammonia into urea, which we'll talk about next. But so the ammonia accumulates, goes to your brain, causes brain problems. But the question is why? Most people don't know this. So among other things, it inhibits the TCA cycle and decreases ATP production. To be honest, this should probably be one of those questions that you know, because this does show up on exams, particularly step 1. So let's talk about why. So it inhibits the ATP production. So let's talk about why that is. Okay, so this is a simplified version of the TCA cycle, right? So remember TCA cycle, the whole purpose of the TCA cycle is to take acetyl-CoA, which just about everything when it breaks down goes into acetyl-CoA, like fatty acids become acetyl-CoA, ketone bodies become acetyl-CoA, ketogenic amino acids become acetyl-CoA, like lots of things become acetyl-CoA, including pyruvate and glucose. And so it turns acetyl-CoA into NADH, 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 and FADH2. And then you get one GTP. For more, I would go to the biochemistry lectures, but that'll suffice for now. What you need to know about ammonia is that if I add ammonia to certain things in the TCA cycle, I will actually form a different product. So if I add ammonia to alpha-ketoglutarate, I will make glutamate. And if I add ammonia to oxaloacetate, I will make, you guys know, aspartate. And if I add ammonia to pyruvate, do you guys know? Alanine. Right, so these are things that you have to know, actually. These are biochemistry questions if you're studying for step 1. These are things that you have to know. Although I would say, generally speaking, I think anyone should know, regardless of what exam you're studying for, why ammonia is bad for you, right? Because in a general sense, it will shut down your TCA cycle and thus compromise, right, decrease your ATP production. That's not good, but it also explains why you feel so bad, like your brain feels so bad, right? Why you feel so slow, lethargic, because it's literally depleting your brain of energy from the inside. Cool. All right. So questions so far? So we've talked about urea, and we're about to talk about urea, right? But we talked about ammonia. So what we'll talk about next is how we eliminate ammonia as urea. We talked about creatinine and why it's filtered because it's small and it's uncharged, and so it'll filter, which is why when you have kidney failure and you have decrease in filtration, you'll have an increase in creatinine. All of these things are important. Cool. Okay, so what is urea? So Jared, what's the purpose of urea?
Urea, isn't it like what you dissolve the ammonia in to get it through the nonpolar barrier?
Oh, interesting. The terminology is it's probably not technically correct, but I think I get what you're saying. Right. So basically, it's a way to eliminate the amine group when you break down an amino acid. It's not really dissolving it. You put literally the NH2 from the amino acid into urea. That's what it is. Like this is urea. So these NH2 molecules come from the amino acids. It's not really dissolving it per se, but you're adding the amine groups to a carbon, and you can eliminate this urea. So you can get rid of 2 NH2s per urea. And so you can use its chemical structure, as we just talked about, to explain the purpose, because it has 2 NH2 groups. And so each of those NH2 groups came from a different amino acid. And so this is how you can eliminate it. Because otherwise, the alternative would be, as Jared said, you just have a bunch of amine groups, right? You just have a bunch of ammonia running around, and that would cause havoc for your brain, which is exactly why you get hepatic encephalopathy, because you can't make urea, right? Because urea is made in your liver. So the ammonia is just going to accumulate and shut down the TCA cycle in your brain. Cool. Make sense? Okay. Yeah, because these are the main groups, basically. Okay, so reabsorption of urea. So Mohana, urea, use its size and charge to explain whether it's filtered through the glomerulus, and then tell us what happens next.
Oh, I'm not really sure about this, but I'm thinking.
Is it filtered?
Yes, it is.
So if it's filtered, what would you guess the size is?
It's smaller than the.
Yeah, exactly. It's got to be
This one.
small enough to be filtered. So yeah, it's reasonably small. Good. And so I think it's also uncharged. Well, yeah. I mean, again, it's going to depend on the environment, but generally speaking, it's probably going to be uncharged based on the chemical structure. Okay.
Yeah.
And so the question is what happens next? And this is important. So what happens next is that it is, in some cases, it is actually reabsorbed, but it is reabsorbed. Okay. So that's important. So this is our urea, right? So again, glomerulus, which is basically a filter. We have urea here that's made from the liver, takes ammonia, and then our urea is going to filter through. It's going to go. As long as ADH is high, right? So ADH is the signal. So if ADH is high, it gets reabsorbed. Cool. So ADH high, your reabsorption.
So is it reabsorbed to maintain the medullary osmolarity?
No, I don't think so. Your medullary osmolarity, we'll talk about this in not next lesson, but the lesson after that. Your medullary osmolarity is maintained by the lubricant, specifically the sodium potassium ATPase. The sodium potassium 2 chloride channel. Sodium potassium trichloride channel, which depends on the sodium potassium ATPase, but really it's the sodium potassium.
So the urea doesn't play a role in the medullary osmolarity?
I don't think so. Is urea absorbed in any other place? Maybe it is.
I thought it was also reabsorbed in the collecting duct.
So it is in the collecting duct. It is reabsorbed in the collecting duct, and it looks like, I didn't know this, but it's secreted into the lubricant. So I think though that the majority is from this. So I don't think that then it could water and urea. I don't think so. Maybe if you could have urea only, maybe it could right here, it can contribute to your interstitial osmolarity. If you only reabsorbed urea and you didn't reabsorb water, maybe. I actually didn't know that. I don't know. But if it does, I think it's going to have a pretty small effect. Actually, no, I don't know. Someone look that up. I'm going to guess probably that's not going to have much of an effect, honestly. But I could be totally wrong. But you don't need to understand urea to understand like why the interstitial osmolarity is high. The only one that you really need to understand for countercurrent multiplication and interstitial osmolarity is the sodium potassium chloride channel, which we'll talk about not next lesson, but the lesson after. Cool. So Nathan, we are constantly making creatinine, right? Because it's a breakdown product of our serum creatine, which creatine is a reservoir for our high energy phosphate bonds in muscles to help cock our myosin heads so that it can bind to the actin. Okay. So why doesn't the level just continue to rise in our blood? Because we're constantly making it. So why doesn't it go up?
I think because it's a secreted product, like it gets secreted in the kidney.
So let's be very careful. So there's 3 ways that your kidneys can affect a substance. You can either secrete it, it can reabsorb it, or it can filter it. So this is really important because it's repeated a lot in textbooks, and it's one of those things that I just memorized for the longest time. I hadn't really thought about why it was important. But which is it that creatinine does? Is it filtered? Is it secreted or reabsorbed? What's the main thing that it does? Because technically it's
probably filtered.
Great, exactly. It is filtered. So they say, right? Well, so because it's filtered, why would that mean that the level wouldn't just continue to rise?
Could you repeat the question? Sorry.
Because our question is, why doesn't the level of creatinine continue to rise in our blood? So you said the filtration, but like, just walk me through. What does that mean? Why would filtration mean that the level wouldn't just continue to rise?
I guess it's the rate of filtration.
Essentially, sorry, that was a read my mind question. That was a bad question. Basically, the idea is that, right, the rate at which we make creatinine is balanced by the amount that's eliminated, right? So the reason why we reach a steady state is because the amount of creatinine that we create at any given time should equal, roughly, the amount of creatinine that's eliminated via the kidneys via filtration. Cool. That makes sense? So that's what we mean when we see steady state, right? Amount in equals the amount out. So the idea, right? So we've got our muscles, right? Now it's a little bit more complicated diagram, but we've got muscles that are going to make creatinine. It's going to go into the bloodstream just like it did before. And so it's going to be filtered through. It's going to make its way all the way through the nephron, and it's going to be peed out. And so the idea is that the amount that we make is going to roughly equal the amount that we are eliminating via the nephron, such that, right, the amount that's in our blood is, right, that like the amount that we eliminate is equal to the amount that we produce. That's it, right? So we always have a little bit of creatinine in our blood. Cool. All right, so Nitin. So like SHOP, organ failure is typically poorly understood by med students, but it does not have to be. So when we say organ failure, really it just means the failure of the organ to do what its key function or functions are. And so what are the key functions of the heart, basically?
Pump the blood to exchange oxygen and
pump blood to the body, pump blood to the heart, or sorry, pump blood to the lungs, or pump blood to the body. Pretty much it.
Yeah.
So based on that, how could you explain what heart failure is based on its function?
So it's the inability of the heart to pump adequate blood to meet the body's needs.
Yeah, exactly. Yeah. So heart failure just means the inability to provide blood to the body. Or you need abnormally high filtration rates. Pretty simple. Paul, what are the key functions of the lungs? I think Paul might not be able to speak. So it's 2, you need to oxygenate the blood and you need to get rid of CO2. So oxygenation and ventilation. Perfect. That's exactly what you wrote. Yeah. And so then Paula, based on your knowledge of the function of the lungs, tell us what respiratory failure means. What does that mean? What are the kinds of respiratory failure you can have?
So would that involve hypoxia as well as hypercapnia?
Well, it's not and, it's an
or. Okay.
It could be both. It's either. Yeah. So you can have oxygenation failure, right? So hypoxemia, your oxygen's too low, or you can have ventilatory failure, which means your CO2 is too high. It really is that simple. Like I used to get so flustered by like these concepts of what exactly is the definition of heart failure or respiratory. Like I would throw out these terms and I'd think maybe I was right some of the time, but really it's quite simple. Just think of what are the key functions. But yeah, so when you intubate someone for, you have to define like, was it because of ventilatory failure? Was it because of oxygenation failure? Was it because of airway protection? That's it. So Priyanka, what's considered the key function of the kidneys, at least in terms of what we're following? What's like the one really key function?
Would be just reabsorption?
That's not what we're measuring, actually. You got 2 other choices.
What did you say right before?
So it's not reabsorption. You have 2 other things that it could be. It's filtration, reabsorption, or excretion. So what's the key function that we measure, that we follow for the kidneys?
Oh, it'd be filtration.
Yeah, it's filtration. Very good. This is why we measure GFR. What does GFR stand for?
Filtration rate.
Yeah, exactly. It's not glomerular reabsorption rate. It's glomerular filtration rate. And that's why also we measure serum creatinine. So Sujith, tell me the key function of the kidneys to explain what kidney failure means.
There's a failure to filter and excrete or reabsorb the vital substances.
You had me at filter. That was really all you needed, right? That's it, right? It's just filtration, right? When the filtration is too low, that's essentially what we define as kidney failure, right? So if you think about like the stages of CKD, right? Your estimated GFR, it's just like a number. What's the number? Technically, stage 1 is when you have like normal filtration, normal GFR, but like other problems. So technically, it's closer to it. Technically, I think you're right. But essentially, right, for practical purposes, we mainly define kidney failure as a problem with filtration. So technically, you're right. Like technically, there's other things like proteinuria and things like that. I think technically those fit into stage 1. But most of kidney failure is defined based on your GFR. In other words, by filtration. Okay, so Susanna, so use the definition of kidney failure to explain what would happen to the serum creatinine concentration.
So it will decrease because
It'll decrease or
we're not,
increase.
like, sorry?
I couldn't hear it. Did you say the serum creatinine should increase or the serum creatinine should decrease?
Well, so we're like, since creatinine is like freely filtered, we're not filtrating, so it will probably increase in the blood, but then decrease in the urine.
Perfect. But what do we measure when we measure someone's blood?
The creatinine clearance.
Sure. Sorry, that's a bad, yeah. So you're saying the creatinine clearance would decrease, but the serum. So what I'm asking is what the serum creatinine concentration. This is an important lesson to learn about reading questions. You have to read exactly what we're asking, not what you think that I'm asking.
So you're asking like what will happen to the creatinine concentration in the urine?
Okay. Again, this is a very important lesson that I want you to learn. Read the question again and tell me what I'm asking.
You're asking like this, what will be the concentration of creatinine if we don't have like filtration working anymore? Basically, that's what I'm getting.
Yeah, but I'm asking what's the concentration where?
Sorry?
The concentration of creatinine where? In your blood or your urine or right in space where?
I think that would be in the blood.
Yeah, great. How do you know it's in the blood?
Well, just like with water serum, it tells me that it's in the blood.
Yeah, exactly. Yeah. Serum is the acellular portion of your blood, the non-cell portion of your blood. Good. Yeah. Exactly. Great. Okay. So I know I don't want you to, well, you can think I'm mean. That's okay. But as long as you understand the point of me being like, I don't know, nitpicky, the thing that I realize, and I wish I could show you guys a question to demonstrate this. The thing that you'll see is that oftentimes you're going to miss questions because you read something too quickly, or usually as a consequence of reading it too quickly, you don't actually understand what the question's asking you. You kind of assume, right? Because in your case, I think, Susanna, what you were doing is you were thinking, okay, like the concentration in the urine is going to be decreased because of decrease in filtration. But that's not the question I was asking you. So if you answer the question based on what you were thinking, you're going to get that question wrong. And in this case, it doesn't matter because you can clarify. Sorry?
Yeah, I agree. I just read it too fast, and then I was like, oh, okay.
Totally. But this is exactly what happens in tests. I see this a lot. And I'm sure you guys, if you go back and you really look at why you miss questions, I'm going to guess that, I don't know, 25%, 20% of the questions, you're missing because you don't actually understand what they're asking you. You're going to go back and you're going to read the question and be like, what? Oh, that's what they're saying? Oh man. And then maybe 20 or 30% of the questions you're going to miss because you read the vignette too quickly. You read the actual, the thing preceding the question too quickly. But yeah, it's amazing because it says serum creatinine concentration, but it's really easy to think, like just to jump to a conclusion and think, oh, talking about urine. But you're right. So kidney failure is defined as a decreased GFR below a certain threshold. So creatinine is constantly made as a breakdown product of muscle creatine, right, which is the high energy phosphate carrier for muscle. So when the substances like creatinine can't be filtered, they're going to accumulate in the blood, which means the serum concentration is going to increase. So, right, we've got our nephron, we've got our glomerular basement membrane, which is this. So we're going to make our creatinine in our muscles, breakdown product of creatine, turns into creatinine, goes, and then if I have a kidney failure, it's not going to be filtered. So it's not going to go into my kidneys. So it's just going to accumulate. So instead of it being eliminated and going all the way out, eliminated, my creatinine is just going to be constantly made, and it's just going to be constantly accumulating because I cannot filter it. Because creatinine is freely filtered, neither reabsorbed or, well, it's secreted technically, I think a little bit. But essentially it's freely filtered, and that's it. Not reabsorbed or secreted to significant amounts. So Shama, oh man, I already told you the answer to this. So creatinine levels are used as a general measure of kidney function. So what special property of creatinine allows for this?
Yeah, you just said it, but already know that it just has to do with filtration, right? So if it's elevated, you know that there's a problem with the GFR elevating the serum.
Perfect. Yeah. Because it's virtually no secretion or absorption. So why did it matter though? Shama, explain to me why that matters.
Why it matters is that the kidneys aren't functioning. So we need to evaluate basically what is wrong with the functioning of the kidneys. Is it a pre-renal injury to the kidneys? As in,
No, sorry. I'm asking why does it matter if creatinine is freely filtered but not secreted or reabsorbed?
Oh, because it's like, it's kind of like a constant in physics. Like it shouldn't ever be altered. Like if it was secreted, that means that there's active like secretion by the kidney to make it happen. If it's reabsorbed, then it's actively reabsorbed by the kidney, but filtration is occurring like passively.
Yeah, perfect. Yeah, so Nikin says you can indirect measure GFR. Exactly. Yeah, it's a way to estimate the GFR. So remember, kidney function is largely defined as the ability to filter, essentially, right? So if there's a problem with filtration, creatinine levels are going to rise proportionally. So creatinine levels can be used as an indirect measure of kidney function. That's why we use it as a measure of GFR. Great. So let's talk about BUN. So Alexa, so use the definition of kidney failure to explain what would happen to the BUN concentration.
So BUN is blood urea nitrogen. So in kidney failure, you're not able to excrete the urea. So that way you're going to have an increase in the nitrogen or the urea content in your blood.
Perfect. Exactly. Yeah. So again, same explanation as with creatinine, right? So you're right. And this time, instead of it being the muscle, it's the liver, right? The liver turns ammonia into urea, which is why in liver failure you have high ammonia. Right? And so your urea is going to go to your kidneys, but instead of making it through, it's just going to bounce off because it can't filter. Probably not even bounce off. It's just not going to filter for whatever reason. And so it's just going to accumulate, just like creatinine accumulates because it doesn't filter. And so you can't eliminate it. So it's just going to accumulate in the blood, just like the creatinine was. Cool? Make sense? All right. So Boogie, so how much of the body's weight is water?
Around 70% of our mass is water, right?
Almost. It's about 60%, but pretty close. So Shaman, how much of this is extracellular versus intracellular?
I forgot, but I think it's about 10 or 15% intracellular, but there's definitely more extracellular.
It's actually the opposite. There's actually more intracellular than extracellular.
Okay.
Trying to think of how we could twice as much as intracellular as extracellular.
Well, then you could just think of it like alphabetically.
I guess so. I mean, like, but think about like, I guess it's maybe a little hard to justify, but think of how much stuff you have dissolved in your body, right? Everything is your intracellular and extracellular space is isotonic, right? So do you think you have more things dissolved inside of cells, like where all the enzymes and everything are? Or do you think you have more things dissolved outside of cells?
I would say inside.
Yeah, I mean, like your body functions like the intracellular portions do stuff, basically. The function of all of your organs is intracellular. So it would make sense that you'd have more stuff dissolved inside of cells than outside. So in order to maintain, because again, the osmolarity of everywhere in your body is the exact same, except for the renal medulla, basically. But everything else is isotonic, everything else. So if I have more stuff dissolved inside of my cells, I have to have more water inside the cell. So Danielle, of the extracellular water, how much of it is inside blood vessels versus outside the blood vessels? Danielle, what do you think? Or how about Deb, what do you think? Do you happen to know of the 1/3 of all the total body water, how much of it is going to be intravascular, right, inside the blood versus extravascular, meaning in the interstitium?
The interstitial 2/3 of the ECF, and the plasma will be 2/3 of the ECF.
Almost. So it's about 1/4 to 3/4. So 1/4 of your extracellular fluid is ECF, and about 3/4 is interstitial fluid. Right. So we're gonna talk about why it's important, but Jared, so why is sodium so important broadly? There's two very broad, somewhat mind-reading kind of answers. So I'll be impressed if you can get that.
I think the first one might be, my bio teacher always said like water follows salt. So like water would follow wherever more sodium goes.
Great. So specifically, it determines your extracellular fluid volume. Great. That is one of the reasons.
And the second would be maybe it's important for neuronal transport.
Exactly. Yeah. So the concentration gradient across the cell membrane is the basis for all action potentials. Just about. Not every single one, but just about. And the serum sodium concentration also determines the extracellular fluid volume. Water follows salt. And because the sodium potassium ATPase excludes sodium, it's going to be outside of cells. So it will determine the extracellular fluid volume. It's the dominant ion. So Lahana, use sodium size and relative importance to explain whether it is filtered, secreted, and/or.
So sodium is really filtered and also reabsorbed at the proximal tubule as well as DCT.
Yeah, it's like you're just absorbed like almost everywhere, right? All those like diuretics come into play. So it's small. It is charged, but it's small. So it's filtered through. So it's hugely important to the body. So you reabsorb just more than 99% of it most of the time. Great. So let's talk about briefly, right? So this is a pictorial representation of, or diagrammatic representation of the total body water, right? So we said 2/3 is ICF, 1/3 is ECF, and then 1/4 is plasma, and 3/4 is interstitial. So Nathan, we said what ion is the largest determinant of extracellular fluid volume, and why is this?
Sodium?
Yep, and why?
Like sheer quantity, like 140 milliequivalent.
Yeah, sorry, that's a bad question. What I'm trying to get you to recognize is that sodium is excluded from cells, right? And the reason that it's excluded from cells is because of the sodium potassium ATPase. The sodium potassium ATPase excludes it from the inside of the cell and makes it go to the outside of it, okay? So I'm going to go through a little bit faster because I want to make sure that we get to the question by the end of this. And so for the sodium potassium ATPase, the number of ions that are moved is that you'll have 3 sodiums that are moved out and 2 potassium that are moved in. And so the reason, so Nitin, why do you see cell swelling as a sign of reversible cell ischemia? Why would that make sense?
So in terms of cell swelling, the sodium potassium ATPase pump is disturbed. So now the sodium will not be able to go outside the way it should be, and it will increase inside, and it will pull more water inside because the direct sodium pulls the water inside.
And the key to recognize is that there's more sodium moving out than there is potassium. So the sodium potassium ATPase should, right, on net, cause more ions to move out than if you lose that, then you'll have more ions accumulate in than out. Okay. The sodium determines your ACF. So sodium, because of the sodium potassium ATPase, is going to accumulate in the extracellular fluid because you have the sodium potassium ATPase is going to kick it out. The ICF. Oh. So yeah, so sodium, if I increase my sodium, really I'm going to mainly increase my ECF, which means I'm going to increase my plasma and my interstitial volume, but my ICF is largely unchanged. Okay, so in terms of kidney failure, our sodium, right? Our sodium should do what, Paula? So Paula, what's happened to our total body sodium? Sorry, what would happen to our blood pressure in kidney failure?
In kidney failure, so you would be losing, you wouldn't be able to reabsorb sodium as much, and hence you would lose the sodium and you would.
But so that's true, but the bigger problem is that you have a problem with filtration.
Oh, okay. So you wouldn't be able to excrete the sodium, you would retain it and you would get like fluid overload and hence like hypertension.
Exactly. So sodium accumulates because you can't filter it. So outside of the reabsorption part, right, if you can't even filter it, the reabsorption doesn't matter. So yeah, so typically in people with chronic kidney disease, you will see an increase in their blood pressure in large part because you have an accumulation of fluid. And so you will often see this. So in the blood, sodium is going to come and then it can't be filtered. So it's just going to accumulate. And so the more sodium you have, the larger the blood volume. Because again, sodium accumulates in extracellular fluid where your blood is, and that's going to increase your blood pressure. So it's just going to keep increasing until, yeah, your blood pressure is just going to increase. Okay. So your concentration, though, of sodium should be unchanged. Because again, gosh, I think Jared or Nathan said that your water follows salt. And so because water is retained with sodium, the concentration is unchanged, even though the total number of sodium molecules in the extracellular fluid has increased. So again, because sodium and water are both increased, it's going to increase, right? It's going to increase the blood volume, right? But the actual proportion of sodium to water isn't changed. So the total concentration of sodium is the same. Okay, great. So now we are back to our vignette. So I want you to go to the session document and we can revise what we had written previously. Cool. For a couple minutes. Okay, so let's look at your guys's. All right, so Danielle, so chronic untreated hypertension leads to atherosclerosis. Sure, I guess it could lead to renal artery stenosis, but mainly it's just going to cause kidney failure. And so, yeah, GFR is decreased filtration, increased creatinine, urea, or filtration, normal sodium concentration, right? Yeah, so you can still be absorbed and secrete enough. Yeah, that's good. That's good basic. Let's look at Sujith. So normal birth, good. Develops hypertension unmonitored, so increased pressure in the renal arteries. Yeah, so it could be renal artery stenosis, but the most likely scenario is it just caused like kidney failure. And so decrease in GFR failure, it's not really acute, probably not acute. So yeah, ultimately it's a chronic renal failure and then increased serum creatinine and BUN and serum sodium. So I would say, yeah, so serum sodium is normal, serum concentration is normal, but the intravascular fluid is up. Good, perfect. So Alexa thing, I feel a little confused as to what you mean by relating the serum creatinine with his blood pressure. Oh, so in other words, what I'm asking is, you want to explain why is his blood pressure high? And what I want you to recognize is that particularly in chronic kidney disease, what you'll often find is that the blood pressure is high. And one explanation would be that high blood pressure leads to kidney failure. But another thing that does happen is that in kidney failure, because of the accumulation of sodium and thus extracellular fluid volume, you will have an increase in blood pressure as a consequence to that. Does that make sense, Alexa?
Yeah, I think yeah. So basically by saying serum creatinine, that's a marker of kidney failure. That's what you're saying by that. Okay.
The serum creatinine itself is irrelevant.
Yeah, I get that now.
The point is that you're not filtering out the sodium as well. And so the sodium retention is causing the fluid overload.
Okay, yeah, thank you.
Billy's asking, if sodium is retained, how do we know that the sodium is not temporary due to the increased fluid load of the RAS? We're still losing sodium. Yeah, there's probably some contribution of RAS, right? Because RAS is activated by chloride to the macula densa. And so presumably if you have a decrease in filtration, you're also going to have a decrease in the amount of RAS. Decrease in the amount of chloride, which means you're going to increase your RAS. So yeah, presumably it's also not just because it's accumulation, but because you have RAS that's increased in a dysfunctional way.
It is also a function of aldosterone increase, which is precipitated by the increased BUN, correct, doctor?
That BUN increases aldosterone? Is that true? I didn't know that.
I thought we talked about the function of what's happening with the mechanism between increased urea specifically. And aldosterone.
ADH increases.
Oh, I'm sorry. Not aldosterone, but that as a function could also be contributing to our hypertension, correct, Alec?
So you're saying that kidney failure could lead to an increase in ADH? I mean, there might be some. Probably not. Probably. Maybe. I never really thought about that. So ADH, the primary function of ADH is to maintain serum osmolarity. So I guess in kidney failure, maybe you could think that there would be an increase in osms. There probably will be an increase in osms. So yeah, maybe there will be some increase in the ADH, maybe. But I don't even think it'll matter though, because you're not going to really be absorbed free water. If it's that bad that you're accumulating osms, you're probably not going to have the ability for ADH to even function. But good question. Okay, so the way that I want you to think about this is, again, so that we talked about the summary of the pathophysiological chronology. Again, I would just think about this as, okay, so you have chronic kidney failure. I wouldn't just, everyone that has hypertension that develop kidney failure, I wouldn't assume that they have renal artery stenosis, right? Probabilistically, it's probably just CKD, probably just kidney failure. Some fraction of those CKD patients will have renal artery stenosis, but it's probably not as many as Q-Bank suggests, because it's a pretty popular concept for Q-Banks. So kidney failure leads to decreased infiltration, and accumulation of things that would normally be filtered is going to happen. So you'll have an increase in sodium, so your ECF volume is going to increase, your intravascular volume is going to increase, which will increase your blood pressure. And as we talked about, because creatinine and BUN are not being filtered, they will accumulate. And so that's why they're high. Cool. So again, this was an attempt for me to go through a basic question and walk through, again, even though it's pretty basic, there's still a lot of underlying concepts here that I think that most people are missing. I wanted to point out the blood pressure increase. And I wanted to point out, again, I wanted to make you think, why exactly is the BUN high? Why exactly is the creatinine high? And why is the sodium normal? The serum sodium concentration is normal. So that was the point. Okay, perfect. So next time, I hope you found this useful. Next time, we're going to build on this concept and talk more about how we can use these concepts to explain the different kinds of kidney failure. So stay tuned. Now that you understand these core IM concepts, you need to know how to actually apply them on test day. In this next video, you'll learn the framework that stops you from missing questions you actually know and the exact test taking strategies that took students from failing to 260 plus scores. Click here to learn how to virtually guarantee a 260 plus in step 2.